whakataka te hau ki te tonga, whakate hau ki te uru, kia makina ki uta, kia mataratara ki tai. Kia hi ake ana te atakura, he tio, he huka, he hauhu, te hei maurua. Te hau kainga, Ngāti tōrangatia, taranaki whānau, o koutou maunga, o koutou awa, o koutou moana, tēnā rā koutou. He mihi tēnei ki a rātou kua whitirangi a tia. Moi mai rā koutou, moi mai rā I tō moenga roa. Ka maumahara tātou ki a koutou, no ake tōnu atu. Āpiti hono tātai hono, rātou te hunga mata ki a rātou, āpiti hono tātai hono, tātou te hunga ora ki a tātou. Our karakia this morning can be translated as, seize the winds from the west, seize the winds from the south. Let the breezes blow over the land, let the breezes blow over the sea. Let the red tip dawn come with crisp air, a touch of frost, and the promise of a glorious day. I then acknowledged the local iwi, Ngāti Tō Rangatira and Taranaki Whānui, and I paid our respects to those who have passed. Ki ake, Barry, over to you, Barry.
Thank you, Peter. And on behalf of the PHONZ steering group, and you will be able to recognise them because they've got the blue backgrounds behind them, I'd like to welcome you all here to our first PHONZ virtual conference. We've been delighted with the support and the response that we've received. When we originally conceived PHONZ, it was to get people together that had an interest in health intelligence, public health intelligence, because we recognise there was an increasing need for that in the new system that we've now got. And my experience is that we've got a very fragmented and limited capacity in those areas, and this was an opportunity for people to join up and talk about things and so on. So we've been delighted, and I think Patrick said to me before that we had 250 people registered for the conference, which far exceeded our expectations, and at some point today there will be about 170 people in line at various stages. So thank you for your support. We see this as an ongoing enterprise. One of our steering group actually wants to have an international one, so that's a promising sign. We have a full program and lots of guest speakers, but I'm delighted to say that Minister Verrall has agreed to open the first PHONZ virtual conference, and we're delighted, Minister, that you've been able to spare the time in your heavy schedule to open the first PHONZ conference. So thank you once again, and I'll hand over to you.
Well, tēnā koutou, tēnā koutou, tēnā koutou katoa, and ngā mihi nui kia koutou katoa. Thank you, Barry, for inviting me to speak today. I'd also like to thank the members of the PHONZ steering group and the environmental health intelligence team at Massey University for facilitating this conference. It's a delight to meet people who care as much about health intelligence and surveillance as I do. So it's a pleasure to welcome you all to the inaugural virtual conference for PHONZ, and with health more present in the public consciousness than ever before, the establishment of a forum for strategic discussion of health intelligence will help ensure New Zealand remains at the cutting edge of this work. Today, what I want to talk about is how COVID-19 has enabled a gold standard of investment and improvement in health intelligence, and how data collection and analysis has facilitated effective decision-making through the pandemic and our opportunities for the future. So the COVID-19 pandemic provided an opportunity for us to establish new systems which we can utilise in the future to monitor and fight public health threats. We've had to build our COVID surveillance system from the ground up, starting with our very first PCR assay just a couple of years ago. Now we have an integrated system with many of the parts that have been developed continuing to play an important role. So we have an automated system that links PCR lab results with disease notification system. We have a gold standard contact tracing system and the underpinning data infrastructure that provides us with insights about disease transmission risk. We have effective wastewater testing. It was able to detect early community transmission during the elimination strategy, and now it has the potential to provide quantitative trends. We've established good processes around modelling disease outbreaks, and that enables us to make decisions about future actions that and the measures we need to implement. And now with a COVID endemic, we have multiple other data sources, including self-reported rats, and we're soon to roll out population-based surveillance of COVID. So I hope the legacy of COVID-19 will lead us to build a stronger public health system, one that can better identify and target future challenges. The pandemic has proven the importance that data plays, and it's vital in making good public health decisions, especially when we need to reduce the rapid spread of the virus. And the legacy of COVID is that it's led us to build a stronger public health system as part of the reforms as well. And that's why we recently launched the new Public Health Agency within the Ministry of Health and the National Public Health Service. The Public Health Agency will lead population and public health policy, strategy and regulation, and will improve health outcomes for New Zealanders. So for example, that's where my current work on tobacco control is being led by officials within the Public Health Agency. It'll also be the location for better surveillance, including of a wide range of diseases. This will mean we'll be able to more easily identify the interventions we need and better plan for serious health issues. Throughout this, iwi, Māori and Pacific providers have shown they know how to protect their communities. And a strong partnership between the two bodies, the Public Health Agency and the National Public Health Service and the Māori Health Authority, will help us build on what's really working well as part of our pandemic response and drive improved Māori health outcomes across the board. As part of our wider health reforms, the new Public Health Agency can focus on the determinants of health across the motu, and it will have oversight of all public health issues, which means better coordination of health promotion and community engagement as well. We can better tackle the underlying causes of illness, such as nutrition, physical activity, and harmful products like tobacco and alcohol. And by taking a preventive approach and getting to these issues early, as you all know, they won't cause a strain on our health system later. So we'll work with the new single centralised public health unit within Health New Zealand, because the pandemic has shown us that there's a risk of a fragmented and under-resourced system. And that's why in Budget 22, I secured $61 million for the National Public Health Agency and the National Public Health Service, and an additional $10 million for better data and digital infrastructure. And just to think about that a little bit further, data is the lifeblood of surveillance, and I don't need to convince you of that, and that provides information for action. The most useful public health surveillance comes from a combination of good measurements and good systems that keep our data functional. The 10 million we recently invested in building digital tools for the wider public health system includes cancer screening registries, COVID surveillance, and will allow observation of other communicable diseases. Several digital tools were developed to support the successful COVID-19 vaccination program, including the COVID Population Identification Register, or CHIPIT, and the COVID Immunisation Customer Support System, or KICS. These are now being used for active surveillance so that we can monitor COVID-19 and other winter viruses, which is particularly important to identify those in our communities who need additional support and protection. High quality surveillance data strengthens our ability to use evidence, science and research in decision-making, promoting better outcomes and innovation. This also extends into clinical settings. In the last budget, the government committed up to $170 million for HERA, the National Health Information Platform. HERA will improve the way health information is accessed and shared across the motu and provide linkages for clinical service provision, for example, joining up primary and secondary care data. This lays a strong foundation for more big data approaches to health research. New Zealand has earned a reputation as a world leader in health datasets, for example, through the implementation of the NHI and the linkage of that with other government administrative datasets. These investments will allow us to continue to lead in data and digital and leverage tools built for the pandemic to serve our health system in the future. As you know, our laboratories are a key component of public health and surveillance, and within this is the crucial role played by ESR. The work of ESR is not recognised and acknowledged enough, so today I want to take the opportunity to correct that. ESR is a key component of surveillance in Aotearoa. They have established surveillance platforms for influenza-like illness across the spectrum, from acute infection in hospitals to syndromic surveillance in the community. They have the ability to rapidly stand up new PCR tests, as was developed for COVID-19, and more recently for monkeypox. Through routine endemic disease surveillance and the use of enteric disease surveillance and the use of whole genome sequencing, we've identified several recent foodborne outbreaks, such as Salmonella enteritidis in the poultry industry and Vibrio parahemolyticus in shellfish this summer. But it is important that we're always looking for ways to improve, and never has this been truer as we seek to continually learn from our largely successful COVID-19 response. And so, in 2021, a review was undertaken of the public health and laboratory science system, looking at the current state and suggesting future directions. Following on from the review, one of the first joint projects between the new Public Health Agency and the National Public Health Service, Te Aka Whaiora, is developing an operating model and strategic direction for the public health laboratory science system. Currently, workshops are being conducted to develop a draft of each of the elements of the operating model. These workshops include representatives from across the laboratory science sector and subject matter experts. It's expected that the draft operating model will be consulted with across the sector towards the end of this year. So in conclusion, the COVID-19 pandemic has made New Zealand acutely aware of the need for dedicated public health intelligence to prepare for short and long-term threats for New Zealanders and their health and disability system. The establishment of a dedicated agency providing a network and a group of analysts who work closely and collaboratively with the Public Health Agency will enable us to have a coordinated health system to achieve the best population health and public health outcomes. By working collaboratively, we can continue to build and improve New Zealand's public health intelligence in creating pai ora or healthy futures for all New Zealanders. Ngā mihi nui.
Thank you, Minister. Now I know that you're available for some questions and answers, and I'm sure we've got nearly 100 people. And thank you for your presentation. Happy to take any, Minister's happy to take any questions that you have. If you do have a question, you can raise your hand using the little gizmo. Is that right, Patrick? And you'll go to the top of the screen so we can identify you.
Yes, you'll find the raise hand button in the reactions menu, which should be at the bottom of your screen. It looks like a smiley face. And then the raise hand button will identify you and help us pick you out of the crowd easily.
David.
Kia ora, Minister. Thanks for your speech there. I just was interested in the 10 million additional funding for data and intel, and I was wondering whether you could expand on this a bit more.
Yeah, thanks very much. So that's a project to build better public health intelligence systems within the Public Health Agency, and essentially involves taking what we've built for COVID and purposing it for other infectious diseases. So one of the, and I believe it includes a fix to EpiServe in particular, because we patched EpiServe up for COVID so it could handle the volume of data and extractions that we had to do from it at speed during the pandemic. And this will make sure that all those infectious diseases data infrastructures is in place and we're able to do what we can do for COVID for other diseases.
Minister, I have a question, and I think it's something you mentioned, is that there is a large number of organisations that fit under the umbrella of health intelligence, public health, that are actually not within the new Public Health Agency, and you mentioned specifically ESR. There are other agencies, and I think of the Childhood Monitoring System in Otago, and there's various others. How do you view those as comprising or being part of this big net, who does what kind of thing? I mean, one of the things, we do have limited capacity. We don't want to reproduce everything. We want everybody steering us going in the same direction.
Yeah, I mean, I think one of the real strengths of our system is that we have that linkage between academic experts in surveillance and diseases and the government science system. And I guess it's kind of, I'm thinking about this more in my capacity of as Minister of Research, Science and Innovation. There's actually quite a spectrum of, if you take the sciences that we need as a service for government in New Zealand, and disease surveillance is one of them, but monitoring of, say, geological hazards is another one. Those services exist within government as part of the wider, let's say, government family in Crown Research Institutes, and then in universities and sometimes NGOs as well. So there's no desire to disrupt what's quite a successful system, and where the government receives a lot of benefit from the expertise that's built up over time in other parts of that ecosystem. I think what I would say is I want us to be a lot more purposive about how we work together. So one of the things about setting up a public health agency is to strengthen the level of and the valuing of technical expertise within the government system, as well as having external experts. And I mean, we've seen that during the pandemic. We started out running everything via external technical advisory groups, but over the course of the 2 years have built surveillance and insight expertise internally. And we just have to do that to be able to make sure that government runs effective surveillance systems. If I focused a little bit more on the model with ESR, I think probably we haven't, I see that as an important first piece of work for the Public Health Agency, because I don't think government has really approached what we need out of surveillance in a strategic way for some time. And so I think that's an important first step to make sure those absolute fundamentals of having a public health laboratory system are in place. And then otherwise, I mean, I think you should just see this as a more exciting opportunity for collaboration with a government that's going to have much better data systems in the future. And I think there's real big opportunities there. I think just as one final thought on that, one of my jobs as Minister of Research, Science and Innovation is making sure we have big data infrastructure in New Zealand. And when I look at who uses the big data infrastructure, the geneticists are eating our lunch, and we have heaps of opportunities to, as public health people, to be using what really will be world-class data sets once we have the system going. So I think if I were back in my old role in academia, I'd be looking to take on PhD students who are skilled in those big data approaches and nesting them within public health groups to really make the most of opportunities that we have in the coming 1 or 2 years.
I see Nick has got a question for the Minister. Yes, Nick? Are you there?
Sorry, some technical difficulties. Kia ora, Minister. I'm one of the medical officers of health up at ARFS. You talked a little bit about surveillance and how it interacts with smoke-free, and obviously the plan and legislation that are coming are world-class and incredibly important. But you also mentioned alcohol there, and while we've got a really great surveillance system around determinants and harm for tobacco, it's not the same for quite a few of the other sort of commercial determinants of health-driven stuff, and particularly in alcohol. So I was just wondering what your aspirations for the health system engaging with that are.
Yeah, thanks, Nick. I think what I'd say is that there's an article by Nick Wilson and Michael Baker from about 10 years ago now, and it's where they took a real systematic approach to basically all of the different types of surveillance you can possibly do, and they identified, I guess, all the way from disease surveillance through to determinant surveillance. And I think if you take that lens, then indeed you see you see that we've got a number of gaps. I engaged with that work about a year ago, and I just think at that stage, with the health reforms at the stage that they were, we basically couldn't progress a big first principles look at what our surveillance needs are. But I think that opportunity comes very soon now that these agencies are set up. And the first priority, as I said, is to get that public health laboratories bit done. But I'd imagine that the public health agencies, early work would be around identifying what our other surveillance needs are that are currently unmet. However, I just will give one word of warning. They can be these when we have looked at some other surveillance work for around nutrition, and just the price tag can be absolutely astronomical when you're talking about going and doing new data collection. So we'll have to make pragmatic decisions around what we can do in that space. But overall, I think we've got a priority on surveillance that I'm unaware of another government focusing on it that much.
Anyone got another question? Oh, one of the things when we set up PHONZ for both the minister and everybody else is that we had an idea that there was plenty, an age-old thing, there's lots of data in New Zealand, lots of data in every health system. The problem is of actually getting that into decision-making and the bit about what we call as intelligence, which is the human capacity rather than people constructing dashboards and nice information stuff. And one of the issues there has been, as I mentioned it earlier on, is the limited, if you like, skilled people are actually asking the so what question, what does it mean, which actually is the basis of the decision making. And I think that's something that as a system, we need to develop the capacity and training in that particular area, that we kind of get lots of people do wonderful things with the data, but in fact, it's the next bit that's kind of missing and asking the so what question. And some time ago, I was talking to people that collect a lot of data, and I said to them, how good is it? And they looked at each other and, well, didn't know. So again, I think there's a niche there for the system to generate more, if you like, intelligent people, intelligence around.
You don't have to convince me of that, Barry. I mean, I guess you'd describe my PhD as being in field epidemiology of tuberculosis, and then all my samples that I collected were given over to a geneticist who's skilled at these big data approaches and comes at it from a very different perspective. And I think that the exciting opportunity is to be building small teams that do contain those, different sets of expertise that bring together the power of those big data approaches, but also the sort of critical and analytical approaches that people who come from a more health background or epidemiology background can bring. But look, we are investing so much money in building proper data systems in New Zealand. And I think if we fail to invest the additional 1 or 2 million it'll take to bring up a cohort of PhD students who can be the future of making all the opportunities out of that, I think that'll be a real missed opportunity. So I'll need your help raising this new cohort of talented people.
It's one of the things that's intriguing.
Actually, sorry, Barry, sorry to cut you off. We have a few more questions coming through in the chat. Sala, you've got a question in the chat. What would you like to ask the minister directly? Or I can read it out for you.
Okay.
Hi, yes, good morning, yeah, good afternoon over here, but good morning over there for sure. Minister, wonderful presentation. I was just wondering, have you touched base? So I'm in the US and I love all the work that's gone on in New Zealand. Dr. Barry Borman, everyone has done just a wonderful job. And I'm trying to do something similar here in the US. So I've worked with folks in Uganda on developing prototypes, and then so I'll be presenting on some of that the last day. So I'm excited about also PHONZ and this webinar platform. But my question is, on the front of all the good work that you're doing in New Zealand, is there any way that other countries can sort of capitalize on some of that work? Have you started having those conversations outside of the country?
Not officially, what a good question. Look, I think we have a small level of international engagement in public health around our COVID response. That's been really, really helpful. I know the public health director of public health and colleagues also have frequent engagement with their Australian counterpart, and our the groups that will be in our public health agency collect insights from other jurisdictions around the world that are very, very helpful. But I guess New Zealand traditionally hasn't had that platform, and when I think of international conferences in public health that I've visited, I've always admired the fact that the CDC in the US, for example, will do their epidemiologic work and then do the extra steps of presenting it at an academic conference. So I think that's something where that in New Zealand would probably be working collaboratively with academics and other partners, and they represent us very, very well in those sorts of forums and disseminate the results of our research very well.
Thank you for that. And I will continue work with Dr. Barry Borman and the rest at Massey University. Great work that's coming out of New Zealand. So thank you for your presentation, and thank you for this platform to everyone.
I know the minister has to leave at 9:30. So is there any final? Peter, you've got one final question?
No, Minister. When COVID first came, the team of 5 million, I think we were all quite proud of ourselves. The death rate was very low, and deaths would come around once every month or so, it seemed. And the other day, I think it was 19. So how are we doing? So is that like a data issue? It seems that we're a lot lapsed now if you measure it that way. How do you think we're going?
What a great question, Peter, and actually really relevant to the expertise of this group in surveillance. So I think we're clearly not in the situation where we can run an elimination strategy like we did in 2020. And just as the transmissibility of the virus and the variants go up, the stringency of a lockdown that you have to use to achieve elimination goes higher. And I think, as we learned during the Delta outbreak, I don't believe these more transmissible variants can be eliminated through a lockdown, because it would have to be so stringent as to be at odds with human rights and people being able to get the things they need for themselves. So we're unable to go back to that policy. But I think so we have to focus, as you suggest, on making sure that vulnerable people are protected and that deaths are minimised. One of the things, there is a little fishhook, I guess, in the data about deaths, and the deaths that we're reporting include a lot of deaths of people with COVID rather than dying from COVID, and that just reflects the really high prevalence of COVID in the community, that many people at the end of their life happen to have it. And one of the things we're going to do is delineate that much better than we have before. And Dr. Bloomfield will be talking about how we do that in line with WHO reporting guidelines next week. So I think that will provide some reassurance that deaths from COVID aren't as high as we think, as perhaps are suggested. And that is I think if you've been following on the Stats New Zealand website, the excess mortality has not been particularly high, except for a very limited period of time during the first Omicron outbreak. And of course, we're very concerned to make sure that we don't end up in that situation again. So that's why I think the reported deaths have been so high, but the excess mortality hasn't. And I think when we adjust our reporting system, we'll reconcile that difference a lot more better. And then finally, I mean, we have to do all the things that I tried to remind the country that yesterday. We have to wear masks more, test more to make sure we identify and then isolate people who do have COVID. I've been very frustrated by the poor uptake of antivirals. You know, we've paid a bomb for some of these tools that are able to reduce trips to hospital by 90%. And yet we do need to do much better at disseminating those, distributing those to the people who need them. So there's it's always doing the basics well, and that's frustrating, but we've got to recommit ourselves to doing the basics well.
Thank you, Minister. I know that you have to go now, and we really appreciate you giving up your time and opening the PHONZ conference. And hopefully there will be an opportunity for you to give another presentation to PHONZ. But as you can see with the number of participants we've got, I think this is fills a niche, and we certainly want it to continue. So once again, Minister, thank you very much for your time.
Thank you for having me, and good luck with all of your work.
Thank you. Okay, that we're ahead of schedule now. Unlike most conferences I've been to, usually we're behind schedule, but we're actually ahead of schedule. And this is the opportunity for, if you like, a more open forum for people to discuss the Minister's speech and anything thereof, or other things. And I think, Patrick, there's a couple of questions here from somebody. Is there?
Yes, there's a few messages left in the chat that the Minister didn't quite have time to get around to. Is the potential for MOH and Health New Zealand to establish an intelligent analyst group similar to other agencies? I think that came from E. Baines. If you're online, do you want to talk about that? See if I can find them. They should be able to reply out loud if they have anything to say.
So can I just ask the participants then, what were the key features, did you think, of the Minister's presentation that you'd like to discuss? It still seems to me that there's a lot of focus on continuing with data acquisition, and the bit that the niche, if you like, that PHONZ is about is the human power, and that's the intelligence bit. There seems to be a lot of focus continuing on data collection and so on in its various forms. So I'll open that up for a discussion.
Kia ora, Barry. I was just going to answer the question about intelligence analysis group.
Yep.
I mean, I didn't quite catch all the Minister's speech as it was read out, but was involved with writing it. And I think she talked a little bit about the ISK group, and there is a team of data analysts and intelligence analysts in an element of that group, which has been very heavily COVID focused so far, but obviously some shifting its focus beyond COVID at the moment.
Right. Any further comment on that?
E-Baines, you can talk or reply in the chat. You're cleared to speak. Technical difficulties, of course.
Yes.
Hi, sorry. It was just coming from a different organisation and now working through Health New Zealand. I noticed that there's a lot of government agencies who have intelligence analysis as a function of their agency which is very different to how the Ministry of Health and Health New Zealand term intelligence. And I wonder if there's a capacity for actually employing an intelligence assessment cell as opposed to like health specific qualified people, but more intelligence analysis qualified people. Is that on the horizon?
As a university person, I can't possibly comment on that kind of thing. Is there any?
Just to say, Barry, I guess the current leadership comes from so it's actually not my team, but a sister team here, which and Dave, who's heading up that work, comes from a very strong intelligence background in defence, and so a lot of experience with the difference between what it means to be producing insights versus intelligence, and definitely has that team on a journey towards something I would say is akin to an intelligence cell, but he'd be better to comment on that than I. But yeah, also happy to continue the conversation if you'd like to reach out, particularly if you're working in Health New Zealand. We should be able to make that connection pretty easily.
Awesome, thank you.
Just on that, I think that there's been, in the time that I've been in the health sector, I think that those words like data, information, intelligence have been treated often synonymously and mixed up. People that are in data often think it's information intelligence. My view of it is that you analyze data to get information, and you interpret, communicate, and disseminate to get intelligence. And it is actually intelligence that gets assessed for decision making. And I think the issue that we've had for a long time in New Zealand is that we've missed that intelligence step out, and we've actually had, I'd call, information-based decision-making. And I think that the focus of PHONZ is to how do we put that interpretation, communication, dissemination into the decision-making, because I think that it's only through that we'll get what everybody seems to want, is a knowledge-based system. So I think that there's a capacity issue. We don't have a lot of people. We have a lot of people doing bits and pieces, and I think it's one of the focuses of PHONZ is to set up perhaps training in intelligence. I think a lot of people fall into it rather than actually are trained in it. So there's some topics for conversation.
Yeah, I just wanted to expand a bit more on that, Barry. First of all, though, Dan, is there, you were talking about the journey of the Intel group at Health New Zealand or the Public Health Agency. As part of that, do they have plans for engagement with the sector? Us who are working out in the regions?
Look, I think the development of PHONZ has sort of occurred in much the same journey as the development of the interim public health agency and then now public health agency. So there's a short-term journey of aligning priorities and structures and function within, and then I'm sure that beyond that collaboration, and I'm pretty sure also the minister mentioned that in her speech, collaboration and engagement with key groups like the PHONZ is very much a part of that future, and very much in a way that we did similar to that with COVID-19, and having a series of technical advisory groups that are sort of close advice to us if possible, as opposed to sort of getting too much of that from an external lens that's not well connected. So a seek to work with and expand capacity through the expertise that exists beyond that, which is purely employed within the agencies, right? The collaboration and connections that were made through COVID-19, but also pre-existing through other groups, to recognise some of our colleagues that have joined into the team, are very strong and very helpful, but I think potentially underutilised in the past. And so doing more of that in future is definitely the intention.
Okay, thanks, Dan. Just expanding on what you were saying, Barry, I think, that PHONZ has a crucial role in looking at the Intel workforce in New Zealand and its development. We all come from different backgrounds and diverse experience, which, is something we welcome. However, there's no competency framework and no kind of accreditation process. So, it's an opportunity for us now, I think, to look at that. What do others think?
I'll just put my oar in there, David. When we were looking at PHONZ, one of the things that I found that there is actually a public health intelligence training course. There used to be in the UK. Chris is online, he might like to comment on that. I think it's actually imperative. Massey runs a thing that's kind of, but not quite there, health analytics, but it's actually the intelligence bit. We can actually train people to turn the handle and produce whiz-bang analysis. But what we actually are not training a lot of people in is the so what does it mean question. And that's, to me, still remains the goal. And it's actually a challenge for teaching that kind of thing to university students, because many of them come through an analytical framework, and what they want to do is whiz-bang analysis because we've got the technology. But I certainly think that's an opportunity, and I'm very keen to develop short courses and that kind of thing. It's a bit of a stretch for university students to actually do thinking.
At the risk of taking the conversation in a completely different direction, we've got a question from Claire Mills about the distribution of intelligence and data.
Yep.
Take it, Claire.
Oh, kia ora. I mean, I would say, just leading from that conversation as well, that it's who's asking the questions, who's being privileged by the questions that are being analysed, and how is it translated back? Because that's what I find most in the kind of work that I'm doing, is that people don't know how to frame the questions, you know, clinicians and managers and so on, but they know that there's things that they need to know. But there's a translation issue a little bit as well. And I don't know whether that's part of the intelligence. I would say it was, but it's from the very beginning. How do we prioritize the questions, and who is privileged by that that already, which I think is an important question in our health system.
Yeah.
And I mean, obviously there are a bunch of stakeholders who have much less access to that intelligence at the moment. So how do we ensure that any new knowledge system, as someone said, democratizes that further, but also allows for a distributed kind of networked intelligence and not something that's just held at the centre?
Yeah, Claire, my comment with that is that it's not just training people to be in health intelligence, actually training managers and above to think that way as well. So it's not just training.
Absolutely. Yeah.
Don't know how you train the manager.
Well, but I guess that's why I think it shouldn't just be a narrow thinking of a workforce of intelligence and analyst kind of people. It's actually, how do we get everybody to upskill themselves around the kind of questions they need to be asking to do their job better.
I see there are some opportunities. Auckland University has some training in digital health. Massey has health analytics as well. But again, I think it's more, certainly the course that we have here is there's more focus on actually using the software to analyze data rather than the thinking about what it means. And we need to start changing that as well.
Yeah, I think just expanding on Claire's comments earlier, I think a key area as well is making the information digestible or disseminating. You know, at the end of the day, we're serving our communities, and we've got to make that the outcome of our information accessible to communities as well. So it's around how we communicate that. It's not just about putting information and interpreting and supporting managers higher up. It's also about engaging with communities with that information. What does it mean for them? And also what kind of information they need.
Vanessa.
Hi, Barry. Hey, thanks so much. Just such a wonderful initiative here, and thanks so much to you and the steering group for putting this on. Absolutely agree that development of relevant skills is critically important. Along with you folk and Massey at Auckland Uni, we're trying to provide opportunities for training. Certainly with our new PG DIP cert in digital health, we're focused on people who are working within health and who are trying to work within the digital health space and trying to support people to not necessarily do the analytics themselves, but to help them to better understand how the analytics can support improvements in healthcare services delivery. So I guess we're trying to work in that space in terms of helping people to ensure that the data outputs are actually going to be useful in terms of improving health services quality, and ensuring that the health services are actually meeting the needs of the community, in addition to improving equity of those outcomes. But yeah, no, I think it's a space where we all need to work a bit better to try to provide more opportunities for optimizing training that is actually going to be useful for our health services. So just great to be part of this network, and hopefully we can help work together to improve, ensure that we know what's available, and also improve on what's available to make sure that we're really meeting the needs out there.
So one more question coming in the chat from Tom. If you'd like to share further, the mic is yours.
Can you hear me?
Yes, just fine.
Yeah, oh, perfect. Yeah, no, looking at our system, one of the things that came back quite often when you looked at all the different evaluations or assessments that have been done, including the one that was mentioned by the minister, by Michael Baker. A big problem is the leadership in the area of surveillance. And looking at what happened around the world, I was just wondering whether we shouldn't aim at developing and implementing a field epidemiology training program in New Zealand, given the success it had in other countries in putting surveillance at a higher level. So that's just an idea I want to put into the discussion.
John McCarthy from ESR, you've written something. Would you want to discuss that? I think John, perhaps he doesn't. I think my reaction to that, Tom, is I think it's a great idea, and certainly one of the things that, as you're aware, CDC has made a very strong view of is, in fact, training field epidemiology. Their I forget what it's called now, health intelligence or intelligence candidates over there, and have a very strong role on that. So I think that John McCarthy from ESR.
Can you hear me, Barry?
Yes, can, John.
Thank you. Yeah, thank you. Somebody just kindly unmuted me. Would you like me to speak to the comment I posted in the chat?
Yeah.
Yeah.
You've mentioned there, John, about the training, and something Tom's just raised is the training of if you like, health intelligence or intelligence people, certainly in the common disease thing. ESR still does that?
Yeah, we still do, Barry. So what we're doing for the remainder of the calendar year is undergoing some stakeholder engagement and just re-evaluating what it is people would like to learn. I think, I mean, as I said in the chat, and as the minister said, we've got a great amount of experience and capability in those spaces, and we're very much outward looking. So, I mean, I would invite people to contact us if it was something they was interested in. We've got a lot of talented analysts that would love to provide support.
Right. I think one of the things that I thought was very good from the minister's point of view is that even though we do have a limit, and from what she said and what Dan has mentioned, that we're working on increasing the capacity in health intelligence, is to utilise all the parts of the system that's scattered, actually fragmented and scattered around in one network. And I think that's a very good thing, because we all come from different areas in this, all with the same goal. So I think that's a very good thing to build on those linkages, and hopefully the steering group folks, we can be a part of that, an integral part of that. Has anyone got any other questions they would like? Ashley Bloomfield is the next speaker, and that's not till 10 o'clock. Is there any other comments from people?
One more from Vanessa.
Yes.
About governance frameworks.
Yep, Vanessa.
Oh yeah, no, I think like all of us here, I'm really excited about the potential of the data, but I'm very conscious that with the increased potential for linking, and the linked data tells the story of someone's life, and obviously there are potential risks associated with that linkage process, especially in terms of data privacy and safety, confidentiality, potential risk of re-identification, even if we take off the NHI and patient identifiers, but also in terms of the way that we use the data. Are we actually going to be using the data to support equitable outcomes? So I guess what I'm really interested to know is from this community, what are people's thoughts around what data governance frameworks do we need to put in place, particularly in terms of Māori as well as Pacific data sovereignty?
Great question, Vanessa, to which I have no answer. But I do think that that's a critical part now, that I know that who uses the data and how it gets used is going to become even more critical with the sort of, if you like, the proliferation of the collection of it. And I think that's something that whoever's collecting the data needs to think of how it will be used and who's going to use it and why it's being used. Peter.
Thank you, Vanessa. That's a terrific question. I work in the Māori Health Directorate of the Ministry of Health, and we don't have all the solutions, but what we are doing is we have relationships with iwi governance groups, iwi management groups, and we are more and more involving them on how and what information we should disseminate to the communities. Like most of the ministry, we have lots of data that we can use and lots of priorities we want it. So we have to prioritize what we want it and work with our relationships and groups on what is the most important to work on. And it's not easy. It's very hard to keep everybody happy. We're a small team, but my colleagues are very motivated and very committed to doing what we can. That's all I can add, I'm afraid.
That's excellent. Thanks so much, Peter. I think I may get in touch with you offline if that's okay, to talk further about this, because it's just so critical.
Yes, another good thing about these types of conferences that we can make contacts like this, Vanessa, and you can see my name there. My email address is peter.hemona@health.govt.nz. I'll put that down in there, and that goes for anybody else that wants to contact me as well.
Okay. Any other questions here? Chris.
Hi, Barry. I don't even know if my camera's going to work. I'm sitting here semi in the dark, as I am in the UK. I'd just like to respond to a couple questions about data security, data privacy, and inequalities. I think we've got a real big problem with that. I'm currently working for the Department of Health in the UK. And the UK has gone all in for something called population health management, which they stole from the Americans and who call it accountable care. And that involves systematic linkage of primary care, secondary care, and social care data. And we've gone down that. And if I see another Sankey diagram, it'll be one too many in the next weeks, because it's dominated by almost a pseudo data science approach. And I think with the healthcare system, because they're so wrapped up in this new technology, what they forget is something that I think most public health people realize, and that is only about 20% of the population are involved in chronic long-term care in the healthcare sector. 80% aren't. And we miss all those people when we focus on patient cohorts and how they move through the system. And the big inequality here is, of course, who didn't make it into the system? I just wanted to respond with that, Barry. Thank you.
Thanks, Chris. And for those that don't know, Chris is actually not beaming in from the rest of the world, the other side of the world, from the UK. Thanks, Chris.
Okay, we've got a question in the chat from Rebecca Gilbert.
Rebecca, do you have a question?
Well, she asks whether Mātauranga Māori data can be included in the, this is a, sorry, it's a question for Vanessa, whether Mātauranga Māori data will be included in the collection and how it would be protected.
So Vanessa, you still there?
Oh, I am, but this is definitely not a question that I can answer. We need some of our people from the PHA and Ministry to answer that question, and maybe that's something we can direct to Ashley when he comes online.
Okay, but Peter's got his hand up.
I just want to let everybody know that on the 29th of July at 9:40, Muellner and Hinemaru Davis Linton are going to talk about data sharing to iwi Māori, which includes data sharing with Māori, and cover a lot of what protective measures and what's disseminated and how that's come about. If you're interested in sharing data with Māori, I recommend that you tune in on the 29th at 9:40.
Thanks, Peter. Can you send the link or whatever you've got for that?
I know, just to jump in, I did a little bit of work for the interim Māori Health Authority, and there's certainly the whole issues around governance and data sovereignty and Mātauranga Māori are on the radar, but I think it's going to take a lot more kōrero and work and thinking before that becomes part of any kind of national data discussion or intel.
Yeah, I thought yeah, totally come in and agree with that, Claire. I think we've got new groups that have just been set up, you know, and very clear that there are intents around this, but I don't think we should expect to try and give all the answers at this session today. The PHONZ conference will provide, I think, some really good opportunities for further thought-provoking ideas, and then we have months ahead to make some progress.
Okay. Just building on that, one of the things that we're thinking of doing for future PHONZ, rather than wait for a year, is to have institute a lunchtime seminar series. So that could be on data sovereignty and so on, could be an opportunity for that. We were thinking, you know, an hour where people can actually get involved more in a workshop kind of operation. And we've already got a couple of speakers lined up to do an extended presentation rather than the 15-minute one now. So that could be something for the future, and maybe Dan, something that, and Vanessa and Rebecca and Claire, we could actually have a roundtable panel discussion on those sorts of topics for the future.
Yeah, be keen to be involved in roundtable discussions for future. Probably just I can't actually do it today, but yeah, certainly at one of the future sessions.
Yes, that's good. Thank you. Doesn't seem to be any more questions that I can see. Patrick?
No, I believe that's anything. If anyone would like to jump into the discussion, do please drop something into the chat or use the raise hand button. That's a great way for me to identify who's got something to say.
And it's just about time for Ashley, I think.
Hang on, we've got a question here from Steve Hazlitt, possibly. Take it away, Steve.
Steve.
I think one of the questions that comes up for me quite early in the discussion, or ought to, is the quality of the data. So I think many of the modelling exercises have been using data recently for COVID, which is not, shall we say, not complete or not even unbiased. I think the quality of it extends to what data collections are necessary to supplement the existing data, including the administrative data, and what can we do to ensure that that's well designed, those are well designed, so things like sample surveys in particular. And I raise this because I'm a statistician. I've been designing sample surveys for 40 years. I felt during the COVID epidemic, for example, this question was not properly addressed. And I think we need to be thinking about what we're going to put in place for the future. I think it reflects what Chris was saying, really, that you can have an enormous amount of data, but if it only relates to part of the population and you don't know the selection mechanism, but you can't actually adjust for it, your modelling goes rather wrong. More a statement than a question, I'm afraid. Thanks.
Thanks, Steve. Oh. Well, I think our next speaker is now on the screen and I can see him. Good morning, Ashley.
Morena Barry, kia ora koutou. Nice to see you all. Well,
Nice
I can
to
see
see
some
you.
of you, I can see a lot of names as well.
And so, Kura Ashley, and welcome to the first PHONZ virtual conference. And delighted that you've given up time on your heavy schedule to talk to us. I should also say thank you on behalf of the country, and many people have done that for your work over the last 4 years, particularly for COVID. Yeah, we're delighted that you're here, and we look forward to your presentation.
Well, look, thanks, Barry, and just want to acknowledge you and your role in helping convene and create and convene this group and this conference. I think over a couple of Fridays, from what I can see, and I know you've had Minister Verrall on this morning already, and you will have, like me, appreciated having an associate minister who's got an excellent understanding of the issues that you're convening around and real vision for how we might strengthen the role of surveillance, of research, of the use of information and data, public health intelligence in the health system, strengthen that in the health system. So look, I thought, Barry, I'd just make a few opening comments, and I can see a number of the people on the call are staff members of mine, and they might want to switch off. They've probably heard me talk about it ad infinitum, but it's lovely to see many familiar names on the call. One of the things, Justin, thanks very much for your kind words. And as I come to the end of my time as Director General of Health and over 4 years in the role and counting down the last couple of weeks, one of the things I've been reflecting on is all the different experiences and input I'd had into my career and what I had worked on as I came into the role, and the people I'd had the opportunity to work with, including yourself at the Ministry of Health, Barry, but people like Don and great public health and public health intelligence leaders who had really given me an appreciation for how to seek out and use data and information to help shape my advice. And that was a really a great asset to me as the pandemic hit. And I found myself surrounded by colleagues both in the building and outside who were with whom I had a relationship and whom I could look to for support on both look at finding emerging data, and there wasn't a heck of a lot of it early on, but also then what that meant. And of course, it's the interpretation of it that's the really important, but the adding value to data so that it becomes not even more than information, it's actually intelligence that then guides decision making. And I'd like to think that we put in place a number of mechanisms to be able to draw on a wider range of expertise through you know, through ESR, through our various technical advisory groups, to actually inform the response, elements of the response and the overall response. And what I can say for those of you who were involved, and my staff will know this, I read it. I read it, and I continue to read it on a daily basis. I get updates still on what's happening around the globe, and that can and should be shaping our ongoing advice. Minister Verrall would have talked about the establishment of the Public Health Agency. You know, it's kind of a great legacy. One of the great things is a legacy I can leave as I leave the role, and in a way a sense of partly disappointment that just as that agency's getting up and running, I'm leaving the role, but also huge confidence in the people who have established it, and those who are in it, and those who are coming in to lead it, in particular Andrew Alden and Nick Jones as the Deputy Director General and the Director of Public Health. And, you know, Andrew, for those of you who know him and or have seen him on TV, sometimes fronting some of the media stuff, he's a public health doc, and he's got a great appreciation for and skills in using data and interpreting that into intelligence and advising on the basis of that. So it's great to see the PHA established, but also in talking with Sarah Turner, who some of you may know, Barry, you may remember Sarah, who's actually been running my office for the last 3.5 years. Not an easy thing to do, but she sort of envisaged or had a vision for a directorate in the ministry as it goes into its new role that is called Evidence Research and Innovation, and that is that's something that's on the so a leader there that's on the executive team, that's a specific function, it's a specific capability and capacity, and obviously there'll be a lot of crossover with the PHA public health intelligence function. But I'm really confident with Andrew coming in, and at the moment Dean Rutherford, who's heading up that directorate, that they will not just work out, not so much where the boundaries are, but how they get those two functions to work together really strongly and complement each other. So I'm feeling really, I'm an optimist anyway, but I'm feeling particularly optimistic about the future of public health intelligence, but also the use of evidence, the commissioning and use of research, and then what that means for both policy, but also how we innovate and improve things across the health system, and in particular in the public health area. And you will also know, Ian Town, who's like me, been somewhat distracted by COVID for the last couple of years, but he's got unfinished business in the organisation. He came in to really drive that research function in the organisation. He's already done an enormous amount there, and my goodness, he's been a huge support for me over the last couple of years, or 2.5 years. But he's staying on, and I know will be continuing to drive that. So huge opportunities into the future, and maybe just a couple of other reflections. I think one of the things the pandemic has done for us, and I can look at some of the names around the screen here: John, McCarthy, Dan, who's obviously part of our team, and a number. We've had the funding and the resource to be able to bring in a number of people who have not just provided us with the internal capability and capacity, but they're people now who, wherever they are in the system, and also those who've been involved in our technical advisory group, we've really strengthened that nexus between the research, information gathering and analysis, and the policy and political interface, because that's actually, I think, was one of the hallmarks of our success. Our success in the pandemic was we were able to really bridge and create a really strong bridge between the evidence and the science, and then the policy advice, the policy making and the political decision making. And I played a role there, but I'm really thrilled that we've got a number of people now who are, and I see them still on a Monday morning, they're on the teleconferences with the Prime Minister and other ministers, talking to their work and able to work really comfortably in that setting, being able to describe what we're doing in the intelligence area and what the implications of that are for policy making. So that's been a huge success and a huge capability strengthening as well that's happened through the pandemic, and one we can build on. And finally, we might get into the questions here. I mean, one of the things that that remains a bit of a challenge is also in doing that, making sure that we're clearer where the boundary is between what the science and evidence and advice is and what our reckons might be. And, you know, we might have a bit of a conversation about this, because I think sometimes the commentary from the experts and the scientists moves, and I've talked about this at a conference before, you know, moves outside their area of expertise. And so I think it's one that maybe we want to engage on, is how do we make sure that those who have got the expertise and are able to bring that expertise on particular issues are not then tempted, as it were, to go beyond where their area of expertise, to say, well, I'm an expert in X and this is what we're finding and this is what it means for public health, because we've I think seen a bit of those boundaries being crossed. So yeah, I'm sure people may have comments on that. Barry, I think I'll leave my comments there to start with, and really hope there are some questions and interaction and a bit of kōrero on that. Thanks again for the opportunity. Kia ora.
Thank you, Ashley. And Vanessa, you did have a question. How will I'll read it out. How will the MOH, PHA, all these acronyms, must be the health system, all these acronyms, HNZ, MHA, work together from a health intelligence perspective, and how will they link with HIRA?
Extremely well.
Of course.
Of course, that goes without saying. Yeah, look, I think a couple of thoughts there. Obviously, within the ministry, we're, as I said, I've spoken to the individuals there, but we're really aware of the need to make sure that the roles are complementary. And I think, again, just reflecting on how we worked through the pandemic, where we were able to bring the skill sets to bear on our intelligence and then on our advice wherever they sat in the system. And I'm thinking here about the work that Gary Jackson and others were doing, and Andrew Old for that matter, and others were doing in Auckland, and how that was kind of just it was as if they were working as we were working as part of a larger team. You know, they were providing at points in time daily updates to us. Those were informing our advice. They were certainly informing what I was saying to the public at the 1 o'clock stand-ups. And there was those technical advisory groups as well that captured people from around the system. Look, you know, we've got these new agencies being set up, but the strength of the agencies will be the ability to leverage the existing relationships that are there, and knowing the people in there, and how we just focus on what's our common objective here. How do we bring these skill sets to bear? And again, I think we find ourselves perhaps in a better place than we might have been if there hadn't been a pandemic, because we've just got into a rhythm of working together, of making sure that that each other's roles is not being done separately, and that we're all contributing to the whole. So I'm optimistic about that as well.
Actually, before another question, one that's come up often in these sorts of discussions is the view that the centre, whatever the agency is, actually does everything. And I think that one of the things that's already come up in our discussion about PHONZ is there's a lot of, if you like, public health intelligence throughout New Zealand. It's not all located just in Wellington or whatever. How do you actually view that working? I mean, there's a lot of groups doing these kind of things now in Wellington. Is that to the detriment of people in other parts of the country, or how's it going to link up?
Yeah, thanks, Barry. It's always a bit of a tension there. However, again, I think the pandemic's shown us ways of, and given us ways of working. Here, our example of how we're meeting this morning, that have become just much more natural. You know, I attended as many Zoom cabinet meetings as I did face-to-face cabinet meetings, which is a very rare experience for a public service official. So if the country can be run on Zoom with ministers all around the place, then I'm sure we can strengthen our the way we gather and utilise intelligence. And so again, I think what we've seen is a move from central, this Wellington-based idea, to national, and just as Te Whatu Ora, Health NZ, and Te Aka Whai Ora, the Māori Health Authority, are national organisations, the ministry, I think, is moving more in that way as well. And a couple of examples of that: Andrew Old is going to remain Auckland-based, knows he's going to have to be in Wellington a couple of days a week, but you know, this notion that all these leadership roles for a start have to be Wellington based. And the other example is there are quite a few ministry staff at the moment who well, not quite a few, there's an increasing number who are actually based offshore, either because partners have been posted somewhere or because for other reasons they've gone offshore. And we've had some amazing work that's just been, we're just finishing off around combating racism in the health system. And the person leading that from John Whanga's directorate is actually in Cambridge, because that's where her husband's been posted. We've got another one who's going to be over in New York because his partner's finishing off a scholarship there at Harvard. He's going to still be doing the work. So I think, again, I think we're well positioned to just reimagine how we do these things, and certainly things don't need to be either Wellington based or even in the centre. It's how we create a collective national effort here. And networks like this are critical to helping us not just meet occasionally, but actually do work together.
Thanks, Ashley. Shanti, you've got a question here. Do you want to ask Ashley?
Sure, thank you very much, Barry, and fantastic to be part of this corridor. My question is basically probably one that's very obvious to all of you, and that is that a lot of the issues that we're talking about don't necessarily reside and stay only embedded in the health system, particularly when we think about who's not engaging with the health system and the people missing in health user data. So I'm just keen to know, in terms of the intelligence functions that you're talking about, the extent to which we're really actively drawing on data from sectors outside the health system. And I'm really aware of the enormous opportunities with things like the joint venture on family violence and sexual violence. It's just one example of places where many agencies come together. So I just want to ask, for example, the group in the Ministry of Health or anywhere else, what are the practical ways in which you're engaging with data outside the health system? They will have their own issues with quality, but I think hopefully many different lenses looking at the same issue, we might see where the gaps are. So that's my question.
Yeah, kia ora, Shanti, and nice to hear from you. Look, I think other colleagues on the call will be able to bring responses to that through your discussions over the 2 days you're meeting, or two half days you're meeting, Dan and John and others. Again, I think this is something that's gone in leaps and bounds. Before the pandemic, we had the IDI. We knew there were already ventures to bring data together. But here's you asked for a practical example. The care in the community response that was established in the first half of this year, that it actually is a remarkable venture, and has not only linked in the space of a few short months, or weeks probably, linked data from across the health system so that it could be brought to bear to provide care to people. So from DHB-based, hospital-based data with primary care, access across the system to a sort of, not a common record, but common information, but also linking that with MSD, because there were, and a lot of work went in to make sure that when people were registered as a case, not only were their health needs met, and have a look at some of the tweets around about how quickly the system's responding. People register their test, then being contacted by their GP within a couple of hours to check that they're okay, talk about their potential eligibility for antivirals, see what supports they need, and then others who may not reach out, then Healthline's calling those people, finding out what their needs are, or one of the telephone providers, and then linking those not just to the health system but to social supports, what sort of other supports they might need. So I think, again, we find ourselves having made big step changes in the linking up of data across the system. Nothing like a silver lining to what was and remains a big challenge. And I don't think there'll be no appetite for going back. I think that gives us a really good base to build on. So there's part of the response, Shanti, but again, others on the call will be able to talk about that.
Thank you, Ashley.
Richard Hoskins, you had a question?
It was more a bit of lobbying, yeah. So what I've said is, speaking of the care in the community model, Ashley, which I agree has been an absolute game changer for COVID response. There are, however, about 60 other notifiable communicable diseases. And in my discussions so far regarding one of those that'll be coming soon, it has been clear that the funding for care in the community, so the technical and funding mandate for it does not cover Manaki for those other issues. As a kind of practical medical officer of health, I never want to use a health order again. I always want to go to a Manaki-led approach. And so my question, sorry, I'm just post-COVID myself. My question is, are there moves to rapidly, formally expand the funding mandate for the care in the community model to cover other issues, including other notifiable communicable diseases?
Yeah, kia ora, Richard. Thanks for that, and thanks for the amazing work you and the team in Waikato have done through the pandemic and for the collegiality. Look, just a couple of comments there. One is, I think it's not just notifiable communicable diseases, and I was pushing personally quite hard, didn't quite get there, but we were, as a ministry, pushing through this winter for that that support, both health and non-health support, to be funded, not just for people with COVID, because otherwise you end up with a two-tier system. We ask people to stay home if they're unwell with identical symptoms, whether it's flu or a rhinovirus infection or COVID for many of them. And then we're saying, do your COVID test. Oh, if it's positive, everything's laid on. Free GP visits. You can even get alternative accommodation paid for if you can't isolate safely at home. Oh, but it's negative, bad luck. You're on your own, but we still want you to stay at home and look after yourself. So we pushed quite hard. We weren't successful at this point, but I think there is more work to be done. And as I said, with a minister like Minister Verrall there, I think this will become something that will stay on the agenda, particularly for notifiable diseases, but also thinking about how do we enable people much more to do the right thing when they have got a communicable disease, including the common ones. And that's not just the health system. Of course, employers have got a role to play there, and many of them have been really, really good in supporting that. And I completely took your point about Manaki's the way to go here rather than an order. Yeah, orders have been a thing, of course, through the pandemic, but they're on their way out, and we need to go back to a much stronger public health Manaki-based approach.
Thank you. Nick, you had a question as well for Ashley.
Kia ora, Ashley. It's in the chat there, but I think, yeah, we've observed a big sort of expansion of lots of our intelligence and operational platforms like NCTS screening and immunization registers and things going to commercial software as a service solutions. Lots of them are on Salesforce now. NCTS is being expanded for measles as well. This has been a big boon to lots of big management IT consulting companies. Do we have a strategy to sort of build our internal capabilities, both for sort of stewardship of public funds, but also to really increase the clinically led ability to be agile in these systems? When new threats pop up, having that internal capability to manage these big commercial platforms.
Yeah, g'day, Nick. It's a really good point, and also just want to talk of the work you and colleagues have done there in Auckland. And I missed your name off alongside Gary's, but I should have put it there. So nice work up there. Yeah, this is a bit of a tension, isn't it? Because on one hand, we will never have that internal capability to develop these systems. What I'm really encouraged by, though, is a shift from the idea, and Shane Hunter, I want to credit in particular with this, the shift from an idea a few years ago, which many countries were pursuing and not getting, and actually spending a lot of money of a sort of a single electronic health record, which would inevitably you'd have to buy into some really big proprietary type function. You'd spend hundreds of millions of dollars and not have any guarantee it would deliver something 5 years late. And now, one of the things, as you say, the software as a service does give us much an ability to develop stuff really quickly prototype stuff, and then get feedback and develop it and iterate it. And I think that's a hugely significant development, and if anything, much more transformative of what's going to happen in the future system than any of the structural changes we might make. But it still then does rely to quite a great extent on external capability and capacity. And so we've probably, in needs must through the pandemic, had to rely a lot on that. And in fact, quite lucky that there was something there. It was all based, Salesforce was there based on the development of the breast screening database. And we were able to springboard off that and develop a whole range of things. And now's the time for us to pause a little bit and say, okay, how much of that knowledge, capability and capacity can we actually have inside our organisations networked, rather than relying fully on the big consulting firms. So yeah, I think that's definitely a next step.
There was another Aaron.
Yeah.
Are you there? Yes.
I'm here. Yes.
Yes. You have a question for Ashley?
Yeah, great, Ashley. It's great to see you and meet you. My question was around more on the genomic surveillance and probably mapping out sort of precision public health aspects, because as increasingly genomic data are becoming available worldwide, so the role of things like polygenic genetic risk scores and mapping out the gene-environment interactions and all of those things are going to be increasingly important over the next, say, pretty much 5 to 10 years as we see this and beyond. So what are some of the strategies that, if you could tell us a little bit about that we are thinking ahead now?
Oh, good morning, kia ora. I'd have to say I'm probably not the best person to speak to that. I don't have any particular insights there. However, and again, well, one good strategy is to have a minister who gets it and will be championing it and understand when we go to her and say, look, here's a direction we think we need to travel. And so I think that's a good start. But I mean, this is an area we could really think about. How do we collectively look ahead and look forward and start to think about, well, what's going to be needed in a year and 5 and 10 years time in this area, and start to not just, I mean, the good thing is we've got some capability and capacity in the system in different parts, and it's how do we bring that together, isn't it? So whereas if you'd asked me 2 or 3 years ago, we would have been starting from a much lower base. So I mean, I think what you've identified is a really decent opportunity, and maybe one you guys can discuss over these next couple of days, and pass on to my dear colleague and friend Diana Safati, who's going to be stepping into the role on the 29th or after the 29th of July. And there's another good thing: someone who will get it and will provide some public health and kind of epidemiological leadership as well. Barry, if it's okay, I might just quick comment on Shanti's point about qualitative data. I can't emphasise how important that qualitative data has been through our pandemic response. We have been doing regular surveys, often from the comms teams, either in our organisation or in DPMC, but incredibly helpful and valuable insights from communities, from providers, community-based providers that have been fundamental to our successful response and guiding our response. And I'd like to think that's an area that again has been strengthened, and that could become a much stronger part of our ongoing, that nexus between public health intelligence and the policy making context and decision making environment here.
Thanks, Ashley. Just following on from that, I've always thought the argument is actually good data, bad data. And people have often said that quantitative data is the hardcore stuff and qualitative stuff is the rest. But I think we've had plenty of instances where in fact quantitative data has been, as Steve Hazlitt says, has been dodgy to say the least. So I've always worked on the mantra that's either good, bad, or you forget about it. We have time for any other question. Is there any others questions for Ashley? Hey, well, there doesn't seem to be, Ashley, and again, we're absolutely privileged that you have spoken to us today, and thank you again for everything you've done. And you're going to put your feet up now, I guess, will you? And read a lot of books and do a lot of walking, perhaps.
Yeah, thanks, Barry. Yeah, that's everyone wants to know what I'm doing next, and the only thing I can say is a decent break. Yep. So my wife and I are planning 3 months work free, and as you say, there's a huge pile of books, and a bit of skiing to be done, and some hills to be climbed, and some trails to be ridden. So looking forward to that. But rest assured, I'm not going too far. And just to thank you and your colleagues and many people I see on the screen here, they know who they are, who have been such invaluable parts of the successful, I would say successful, and Barry, you know, there are a lot of books to be written about the pandemic, but one of the important books is just how successful we were in creating that very, very strong bridge between the science, evidence and intelligence and the policy and political decision making at a time of huge uncertainty. That was the thing, and we had a number of things in our favour, but the thing that was probably most in our favour was the talent and capability we had around the country, and the fact that we had strong relationships that we were able to leverage that capability and just bring it all to bear at the right time and in the right place. And I'm proud of what we've achieved as a country. So thanks so much to you and your people for what you've done.
Well, you can be proud. Reflect on it proudly, Ashley, and go well. And it's been great having you. And maybe we can keep you on tap for your reflections in future PHONZ meetings when you're a bit more out of the political limelight, perhaps.
Yeah, that's right. I'm very keen not to become a commentator in the future. The commentators have been the bane of my life for the last 2.5 years, particularly the ones who commentate on areas where they have absolutely no expertise. Anyway, Barry, all the best with the meeting, and yeah, I'm certainly available to talk again in the future, and we'll see many of you around, I'm sure. Good, thank you, Ashley. We'll take you up on that. Okay, thanks very much, everyone. And as we were discussing before in the steering group, one of the advantages of having an online meeting is that you don't actually have coffee breaks, and we do have a lunch break, but there's no coffee break. But let's move on, and it's my privilege to welcome actually two people I know, one particularly from a long way back. In fact, I sent him a photograph and he didn't even recognise his own photo, he told me. So that's Graham Cameron, and the other person is Maria Poynter. Now, it is a joint presentation, or sort of, is it?
No, it is a joint presentation.
I did.
In the sense that they roll into each other, yes.
Right. So Graham is the Acting Director of the Public Health Agency, and you've heard a lot of comment about that already. And Maria is a public health physician and is going to talk about the National Public Health Service. And as your first, Graham, you're going to start the rolling off, are you? Good.
Yes, I am.
Thank you very much.
Sorry, Graham, before you kick off, perhaps for the benefit of yourself and the other presenters today, I should quickly explain how we're going to be keeping you to our schedule. So you'll see from the programme we've allotted all our presenters a 20-minute slot, so that's 15 minutes presentation and allowing 5 for Q&A. So to keep people to that, at the 13-minute mark, when there's in theory 2 minutes left in your presentation, you will hear this noise.
Terrible, isn't it? That's a $4.50 bell.
Excellent, thank you, Patrick. It's been a long time since university debating, but I feel like I'm right back there now with the bell.
Oh, it's an old system, but it's effective.
Thank you, Graham.
Okay, bye. I'm just going to share my screen. Hopefully you're all able to see that. Look, nei rata mihi kia koutou, I te tuatahi ngā mātanga i ngā rangatira o te Public Health Observatory, mihi kawana tēnei uri o tauranga moana kia koutou. Good morning, thank you for the opportunity both to be here and listen to the Minister and of course Dr. Bloomfield, and it's a pleasure to be able to talk to you a little bit about our work. And answer that question, You know, the relationships between ourselves and the National Public Health Service and Te Aka Whai Ora are absolutely central to the achievement of a lot of the aspirations you've been talking about this morning. So just to start with the Public Health Agency, that idea of relationship and the centralising of equity and te tiriti waitangi is part of, and that story is part of the branding that we have there for the Public Health Agency. So just by way of starting, the first thing I'd comment on is, it's been referred to throughout the morning, but there are some very key relationships in the new health system, and elements of this diagram have been floating around for quite a while. But just to say that the clarification of roles between Manatū Hauora, Te Whatu Ora and Te Aka Whai Ora, I think, have come a long way from where we were this time last year, and our understanding of where we sit. There are still rub points, as you can expect, and a lot of those will be worked out as we're moving along. However, in terms of the Public Health Agency, the key function for us is really in that strategy and policy, and then in the surveillance system, and therefore providing support and guidance to the National Public Health Service, which Maria will talk about later on. So the Public Health Agency, in terms of our strategic intent, obviously the whole health and disability reforms has as its focus pai ora, so achieving healthy futures for all. The kind of key aspects that the Public Health Agency is focused on: the wider determinants of health, and if you've followed the politics, you'll know that's in the Pai Ora Act itself. Equity, and when we're talking about equity, we're talking about specificity and intersectionality of issues rather than some kind of generic label, so understanding equity. And so that means there's a real key role for elevating whānau and community voices in our space. Te tiriti waitangi, and particularly the findings of Y2575 have been really central to what's happening in the reforms and for Manatū Hauora and the Public Health Agency. I guess the key thing I would say is moving past this idea of relationship and consultation with tangata whenua to actually understanding that as a partner, they also have a place for self-determination, for authority, and for control as well. So those relationships with Te Aka Whai Ora, iwi Māori partnership boards and Māori communities are absolutely central to our work. And the key threads there that you see, those really represent the 5 system shifts which are at the heart of the health and disability reforms. Then we start to drill down into some of the functions of the Public Health Agency. They're kind of 5 core functions: public health strategy, policy and regulation, public health leadership, that's the Office of the Director of Public Health, and 2, I think, relatively new for our space, but central ones: intelligence, surveillance and knowledge, which no doubt we'll talk more about later, and population health and equity. So that's not an outcome, that is a function in the Public Health Agency. So intelligence, surveillance and knowledge. For the Public Health Agency, our role is to co-design and co-decide public health intelligence and knowledge so that it informs strategy, policy, regulation and monitoring across the broader health system, including, of course, population and public health actions. There are broadly 6 key focus areas for us in this area: leadership and oversight, of course, of the public health knowledge and surveillance system, the development of data standards, requirements and surveillance tools, analysis, interpretation and thought leadership, to be clear, in relation to strategy and policy rather than operational, visualization, dissemination and communication of all that information, and then the application of that knowledge into action, strategy, policy and decision making, and evaluation and quality improvement, again in relation to strategy and policy. What I would say is this ties really closely to Manatū Hauora's key function, which is as the system steward or the kaitiaki of the system, which is the overall system achieving what we are hoping to achieve in relation to pai ora, and particularly in relation to equity for underserved communities and our te tiriti waitangi obligations. On that, that has been a big part of my focus and my role in the Public Health Agency, and it is a big focus of the Public Health Agency overall. Obviously, the reform signalled a reorientation around this in public and population health. And so that critical shift that we're looking for is about fulfilling the special relationship under Te Tiriti and achieving equity for those communities who are underserved. So our role in all of that, a strong partnership with the Māori Health Authority, with Te Ako Whaiora. In many ways, their functions parallel our functions in relation to population and public health. And that includes servicing the needs of localities and iwi Māori partnership boards. And in our strategy and policy, having a focus on where are points where we can devolve power to iwi and Māori communities rather than it all sitting with the Crown. Obviously, we need to provide expert advice, strategy and policy to advance population and public health. The intelligence, surveillance and knowledge system is absolutely central to that, because it's that insight to equity that will be so essential to understanding whether we're achieving paiora. So we need to be informed by community of whānau voice. And then the other very important part of our work program is understanding the wider determinants, understanding how to prioritise them and how to embed them into our work program. So to do that, at the moment we have an interim structure, but just briefly on that, as has been referred to already, Dr. Andrew Old is starting on Monday as our Deputy Director General Public Health Agency, which is very exciting. In the top box there, I guess his core leadership team in driving these aspirations. It's the Chief Advisor Hauora Māori, which is my position at the moment as interim. There's the Director of Pacific Health, which is Geraldine Clifford-Lidstone, and the Director of Public Health, and I think you will have seen that it was announced that Dr. Nicholas Jones is starting that position in the 15th of August. Now, in addition to that, there's a senior leadership team. There's the ones you're aware of: policy and regulation, strategy, intelligence, surveillance and knowledge, public health leadership, which is the office of the Director of Public Health. Some other ones that are in there: emergency management and global health, also part of the Public Health Agency. And you'll see the box to the right: equity and population health, Chief Advisor Māori Health and Director of Pacific Health. We really operate as one team, and the key focus of that is equity, an equity lens across the work program of the entire Public Health Agency, understanding our tiriti obligations alongside the Māori Health Directorate and Te Ako Whaiora, and driving the determinants work program within the Public Health Agency. Looking forward to the bell. The Public Health Advisory Committee is obviously something else you may be interested in. It's going to be up to 7 members. It's an independent committee. Just for your interest, a short list is about to go up to Minister Verrall, who was here today, and so we expect that she will be making some appointments in the next month or so, with the hope that perhaps we'll have the first meeting in either September or October this year. A key partner to them is the Hauora Māori Committee, and so their Secretariat services are provided through the Public Health Agency, but they are independent, so it is quite possible that they would want to drive areas of policy and strategy that are not already part of our work program. And with that, quite proud of my timing actually, I'd like to hand over to my colleague Maria. Kia ora koutou.
Tēnā koe Graham, tēnā koutou katoa, ngā mihi nui kia koutou. Barry and the team putting together today's conference, it's really great to have the opportunity, so thank you. And thanks Graham for expertly driving the first part of our joint presentation. Ko eo he tangata tiriti atau no airana ko te rana me hutine o tipuna. Ko Randolph Te Waka no Tāmaki Makaurua hau ko Maria Poynter tōkuinga. I've been acting as interim clinical lead or co-clinical lead in the National Public Health Service since February this year, and that's a part-time secondment from my day job, which is as clinical director at Auckland Regional Public Health Service. So this presentation is really bringing in a flavour of the National Public Health Service's thoughts and aspirations and where we've got to so far, and really works in with what Graham's presented from the Public Health Agency's perspective. And I can't forget our third partner in our three-way agency grouping, Te Aka Whaiora Māori Health Authority, which you'll see and I can refer to as we go through this presentation. Graham, I'm going to need you to do my sliding. Thank you very much. So just a quick overview of where we'll get to today. Just really covering some of the functions of the National Public Health Service within Te Whatu Ora, Health New Zealand. We can give you an update on structures for the National Public Health Service part and also where they fit in with the wider Te Whatu Ora leadership team. Starting to talk about some people, so you'll see some roles in place, and there were some further ones announced this morning for the National Public Health Service. And some thoughts on our priorities, particularly as they relate to intelligence and knowledge, and our process for transformation around collaboration and engagement. Thanks, Graham. Next slide. So just as the recapping, so I did put this in having pre-awareness that Graham was going to talk to it. Just a reminder, as Graham's talked about particularly the Public Health Agency responsibilities and kind of lead roles within our public health system structures. The National Public Health Service in the bottom box there is part of Te Whatu Ora. The various cabinet papers and Act talk about it being within Te Whatu Ora, but having a relationship across to the Māori Health Authority, and we'll pick that up in the next couple of slides. And if you're wanting a elevator pitch, our work is really around the planning and operations of public health work, and particularly leading out on that delivery approach. So taking our lead from policy and strategy that is jointly worked out through the Public Health Agency and Te Aka Whaiora, and putting that into practice. But of course, because it's a partnership, we also have a role to play in kind of sharing that back. So it's not a one-way relationship. We can provide some of the insights to the PHA and Te Aka Whaiora as in our way of working. And we're also still working through our relationship with the wider parts of Health New Zealand. So the National Public Health Service is around about 1,500 FTE or people, and the wider Te Whatu Ora work population is around 80,000. So we're a smallish part, and there will be parts that cover public health in the non-NPHS parts of Te Whatu Ora, and we are pretty intent on forming some really strong relationships, and have already started to do that with teams around commissioning, around the localities work, and around the intelligence work where that sits around both data systems. And I know we've got next speaker around data collections, and also intelligence in terms of what information feeds into commissioning, both from the planning and also the contracting perspective. Thanks, Graham. Next slide. So this is our day one structure. We are at the point, so what you'll see with the big line across the sort of the middle of the page is our tier 3 structure. There's actually a box that's disappeared in colour, but on the left-hand side. But I'll just talk you through this. So we've got our National Director, who is Nick Chamberlain, who has started in the role. The blue box off to the right is Nick Jones as the new incoming Director of Public Health. So that's because the Cabinet and legislative documents specifically talk about that role being situated within the PHA, but having a leadership role that extends across into the National Public Health Service. We've actually just updated this structure as of this morning. So in addition to the Office of the National Director at that core enablement team level, there's also Māori and a Pacific lead advisor roles that are going to report directly to Nick as well. And then if we come down to the core tier 3 structure, we've got on the left-hand side 4 regional directors. So you can only see 3 because one is magically turned white. And they are the Northern, Te Manuataki, Central and South Island or Southern regions. So that maps to the Te Whatu Ora regions. And then on in the middle, there's a Director of Transformation, which will lead out on a lot of the function and structured change work that we'll do over time in a planned way to NPHS, both as we're starting to think about what works for the future, but also about in terms of functions, but also potentially in terms of structure. So just a little bit on that, our approach, given we had quite a short time, was to transition in all of the teams that we knew needed to end up in NPHS. So that includes the 12 public health units or 13 public health units, depending on how you define them, that you can see off on the left-hand side under those regional directors. It also included the whole of Te Herenga Hauora, the Health Promotion Agency, and that sits under the Director of Promotion there. And then it included quite a number of the ministry teams that were off on the right-hand side, including screening and immunisation and COVID functions, etc. So the approach was we'll bring everyone under the same roof, if you like, but we recognise that the first thing to do is to make sure that we don't drop any functions or delivery in the meantime. But after that, we realised that we need to do some readjusting. And so the analogy we've been using is that we're all moving into the same big house from a number of little houses. And as we move in, we're kind of unpacking some boxes, but realising that some of our boxes are actually going to end up in different bedrooms, if you like. That's the role of the Director of Transformation, essentially, is to do that over a period of time. The blue dots I want to focus on, they are where we've talked about a joint role or relationship with the Māori Health Authority. The way that the Māori Health Authority is working out how it wants to approach their strategic priorities and approach is that their structure won't map, and nor does it need to, either the NPHS or the PHA in terms of the public health components. So we've got blue dots on the roles that we see will have a direct and probably named relationship with a role in the MHA and Te Aka Whaiora. And we are continuing to work with them on a weekly basis as they're starting to bring people into those roles, and will do so permanently, but particularly over the coming months as we're getting our switch from transition to transformations really up and running. From that intelligence, knowledge, surveillance perspective, there's a couple of things to note on this. We, on the very right-hand side, we have put in a Director of Assessment and Surveillance. The reason for that is that there's a lot of information that needs to be received from or into NPHS. So for example, if we're thinking about health promotion, there's obviously huge amounts of data that go into case and contact management, and the reworking or analysis of that data in order to support operational responses. And so that the reason for having that role there at a tier 3 level is to make sure that we start to get a really good planned approach for that. So we see that role working quite closely with the Director of Protection and Outbreak Response around COVID, but also other health protection response work, but also potentially over time, and this is some of the transformation stuff that we won't do without more collaboration with our workforce. Potentially they could have more of a role in some of the other work across the structure, so things like screening and immunisation or other public health unit work. And the extent to which that happens versus the extent to which it stays really operating at that national level really depends on the work and kind of design collaboration that we roll out over the coming months and years through that transformation work program. I'm going to get Graham to move to the next slide, please. So this is just a reminder of the Te Whatu Order structure. Many of you will have seen this before, but just showing you where the National Public Health Service fits in the bigger scheme of things. You can see that Margie's role, the Health New Zealand CE at the top there, has sort of 4 key groupings within her leadership structure. The orangey one is the delivery leadership team, and the National Public Health Service sits under that. And then there's a line down to regional directors. So a regional public health service will sit those regional directors on the regional management board, which is quite useful and hasn't always happened across our current structure that we've had, or our old now structure that we've had for the last 22 years. So we're really looking forward to the opportunity for having public health voices at that regional management leadership table. I mentioned before some of the other key parts of Te Whatu Ora where we are thinking we'll have really strong relationships. They are include in the enabling leadership team, that data and digital and infrastructure investment type enablers are really important there, and I'll come back to the data and digital in a second. And then within the delivery leadership team, commissioning and the localities work will really play a key role in the particularly non-communicable disease parts of public health. Thanks, Graham. Next slide. This was my placeholder slide because I was hoping to be able to share the Tier 3 director, so the assessment and surveillance director. That person hasn't been named yet, but it's pretty close to being finalised. So watch the space slide in the end, or if you don't like that, you can look at the picture of the dog on a beach. And next slide. Thank you, Graham. So what's our approach going to be? So Graham's talked about the key priorities for a public health agency. We are a little bit newer than the PHA in terms of the amount of time that we've had to sort through our work program. So we're still getting there, but we're broadly looking at that in 3 groups. The first priority is to enable operations, and I talked about that in terms of we just need to get in there and make sure that we continue to deliver, because as the operational service delivery end of public health, we need to not drop stuff just because we've changed agencies. So the first thing is to make sure that our operations continue. The next thing we need to focus on is really addressing some immediate priorities. There's quite a few in the intelligence, knowledge and surveillance space. So we are working through some of them. So there's some around access to data, just making sure that we can continue to have a more collaborative approach across the country for some of our response work. Those of you that are working in public health services at regional level will know that we've been working on the NCTS and expanding that to enable measles cases and contexts to be dealt with. So that's an example of where we know that there's a potential gap if we had a measles outbreak at the moment, and so the COVID team within what was the ministry, now the outbreak group within the National Public Health Service, has been working to allow that to happen in the event of a measles outbreak, just because we know that the data requirements get pretty huge pretty quickly, and so we need to have a system in place. There's some other immediate priorities to do with workforce and data and digital, and they will be priorities for the transformation group and for the other Tier 3 directors. They are, without going into them in too much detail, it's basically enabling the enablers. So we know what the NPHS can do. Some of it is not as efficient as it could be because we've got things that stand in the way. So we're really about clearing the paths to enable that to happen. And then alongside that, we want to start some of our design transformation work. So we, next slide, Graham. What we're kind of planning to do with that is we need the people in place. So our Tier 3 level is mostly named now, not quite all named. So assessment and surveillance is one of those where it's not quite there. We're making sure that our operations are stabilised and that we enable that delivery. The next step around our transformation program will be that we want to make sure we're doing the right thing, and that includes talking to people that have been doing this work for a lot longer than any of the Tier 3 people have. So there will be, I think it's fair to expect that you'll be asked for your views if you're working within NPHS, and that you'll be kept aware of what's going on if you're not working within NPHS, but are working in the sector. It is a bit of a plea, I guess, to kind of be aware that there will be several priorities, and so we have to work in a planned and phased approach so that we address those immediate priorities that are areas where there needs to be some risk mitigation, but also don't dampen down the really big potential that we have in creating this new structure together. We will be requesting feedback. We won't be kind of designing and letting the ink dry on things without lots of feedback. And over time, we're hoping to have a lot more interaction, not just within NPHS teams, but across the sector. So, for example, working with PHA and Te Whatu Ora on what are we seeing through our our operational teams? Are we collaborating on that? Are we getting a really good picture? So it's sort of some of that stuff that Graham's talked about and the comments before around qualitative evidence are really important. We know we can do better around connecting. And we're also hoping to have more visibility of the National Public Health Service across New Zealand, not only in the public health space, but kind of putting it on the map. So COVID put public health on the map in many ways. What we would really like is for the National Public Health Service as part of Te Whatu Ora to be a known sort of brand where it has a front door, people can approach the NPHS for advice and for informative products. I think that's the last slide, Graham. I think there's just an end slide, so happy to stop sharing, and I think the bell hasn't gone, which means there must be some time for questions. Thank you, Graham.
Thank you, Maria and Graham, and that's a bit unfortunate because Patrick didn't get a chance to ring his bell, so you're obviously a great timekeeper when you talk. We actually do have a number of questions in the chat, and Shanti, you've got a question, so we'll work through those as they've come up.
I think the question is pretty obvious from what I put in the chat. I'm just conscious of how important it is, some of the cross-cutting themes across all our work programs, in particular fertility responsiveness and commitments. I'm just conscious of the limited capacity and the number of people for whom these can become significant cultural loading added jobs. How are the various structures that we're talking about, and we've seen lots of the diagrams, actually using the capacity we have so that we are not duplicating efforts across while still wanting to ensure we have the most robust engagement possible? How's that being managed?
Would you like me to start, Maria? Look, it's a fantastic question, Shanti, so thank you. So in terms of Public Health Agency, I guess the central element is the relationships we have within Manatū Hauora and then across the health sector and acting as one team in that space. So, for example, our key partner in Manatū Hauora is the Māori Health Directorate, kia ora Peter, and from the Māori Health Directorate into Te Aka Whaiora, and working on a number of shared projects in those spaces, rather than locating them just in the Public Health Agency, and at the same time building Hauora Māori capacity within the Public Health Agency as well. And so in addition to that, there's some core competencies as well that our workforce needs to have. So it can't be loaded on tangata whenua to just carry that load. So being tiriti led, anti-racist, pro-equity and culturally intelligent competencies that we'll expect across our whole workforce. So workforce development is going to be an enormous part. And then alongside our Pacific colleagues, there needs to be a workforce pipeline. What I mean by a pipeline is investment can't just be in our normal ways of gaining qualifications, and we actually need to bring people from all across our communities who want to work in the space and make that possible for them. So it's complex, it's not going to be solved in short term, but absolutely recognise it's an issue. So kia ora.
Thank you.
I don't think I have too much to add, really. Like Graham's unsurprisingly done a really model answer, just noting the workforce elements are very much front of mind for, so workforce development, people development aspects are very much front of mind for NPHS as well, and that will be a significant area of investment. On the extra loading, completely understand that. And we're challenged by that every day, frankly, because we would love our Te Aka Whaiora colleagues to be able to have capacity to be across everything and be and not have to prioritise their work. It's one of those things where we talk about bring your tools quite a lot to everyone in the sector, because we can't rely or put too much pressure on our Te Aka Whaiora colleagues.
Thank you. Vladimir, You had a question for Graham and Maria. Yes.
Thank you. Thank you very much for that opportunity.
I can hear you.
We are here in Northland, and we want to understand the vision how the local, what is currently public health units, and especially Intel teams, and how they will be connected to the overall mainstream work. Thank you.
Okay.
Yeah, so that is the question. So how the local.
Yes, sorry, Vlad, your microphone is very quiet. We're having trouble hearing you.
I think
is it better now?
Much better.
Now, yes.
Okay, so the question is how the current local public health unit Intel teams, I'm an Intel team, so that's why it's the main question, how they will be connected to the mainstream work, the lot of challenges which are discussed here and mentioned earlier. So the role of local public health Intel teams.
Absolutely. So we still need local intelligence. And when we're talking about building the system, we don't have anyone in that assessment and surveillance group yet. So it's a structure to build into. We don't plan to get rid of the need for local intelligence. That will always be there, whether it's quantitative or qualitative. But what we're hoping to do over time is to have a much more networked approach. So that means that we are meeting weekly and working together with the wider Te Whatu Ora data and digital team, and there's some big projects there around systems that enable data to be inputted and analysed and better used across the system, so that we're not reliant on kind of bespoke local approaches. But in addition to that, having a national assessment and surveillance team means that we can start to get some data science processes and products and that sort of thing in place that are much better able to respond to the needs of what we need. And in particular with that, I think a more embedded approach to what the assessment and analysis that we do is, particularly picking up on a key system shifts around TDT and equity analysis. So it's more a case of the assessment and surveillance team not taking over the work, but being able to sort of stand back, take that national approach and support investment in some of the structures and functions to be able to do a better job all round.
Thank you very much. And please keep us in loop. We here in Northland have quite interesting team.
Yeah, you had a message, a question too.
So,
Claire?
no, thank you very much. That was my question, and I got the answer. Thank you.
Oh yeah, my question's really more about the general structure within Te Whatu, not just Te Whatu Ora, and not just, I guess, the National Public Health Service. But I just wondered about the views of Graham and Maria around how the future state would look, because at the moment it seems a bit like we've got the public health units staying as they are in sort of 19 districts or whatever we've got, having district management still, and health promotion still sitting out in another block. I mean, is there any vision yet developed of a broader integrated public health service at a more local level, or is it just going to be the same old but with an extra management level at the regions?
Thanks, Claire. I'm probably not the person to answer a question around districts, because within NPHS we're really not talking about districts very. It's something you might need to ask to the wider Te Whatu Ora kind of Q&As. But from the perspective of where what we're PHU, so we're trying to call them public health services now. What we don't want to do is break the parts of the system that are already working, and that's particularly around local relationships. What we do want to do is to enable some of the efficiencies to be able to create more space and time, if you like, to do things that work on a local level. So sometimes that's a district because the kind of local PHU maps to a district area, I guess, but sometimes that's very much more a region than a district. I don't think there's a need for the National Public Health Service teams to get to feel like they need to engage in structures that don't apply to them. So if there's not a district kind of approach in a PHU or PHS area, then there's no need to kind of create a new level. I agree with you on that one. In terms of the written comment around IMPBs, iwi Māori Partnership Boards, I am not aware of, you're probably more up to date than I am around later conversations around how IMPBs map to districts and regions.
Yeah, kia ora, Maria. Picking up on the iwi Māori Partnership Boards, you're quite right, Claire, that they don't map to that structure. And indeed, the expectation, I think, is because they're working with iwi boundaries, they won't necessarily map to localities either. So from a public health agency perspective, Manatū Hauora perspective, really this comes back to, if we are serious about the tiriti relationship, then we need to resource engagement at all of these levels. And that is more complex than what we've done in the past. Again, iwi Māori Partnership Boards could choose as a collective of iwi to decide that they are the tiriti partner collectively, but actually well within their rights to say that as individual iwi or in different structures what the tiriti partner looks like. So really it's the Crown our responsibility to resource the relationship however it lands, rather than dictating to them how exactly that should look. And that will be enormously challenging because that's a new part of the system, but one that we're all committed to making work.
Thanks, Graham. Thanks, Maria. Any other questions? Rachel had a question. Answer the question, will there be a focus on preventing non-communicable disease? If Rachel's around, do you want to answer that question?
Yeah, thanks. Yeah, that is my question. We need to expand. I was just wondering about the focus on non-communicable diseases prevention.
Do you want me to start, Graham?
I really do, yes.
I'm not sure whether you were meaning within a particular structure, Rachel, so feel free to kind of clarify, but we can talk more generally. Non-communicable disease is massive. We all know that, yes, COVID's been the glory sort of thing for public health in the last 2.5 years, and the Tamaki Makaurau region, there was measles in 2019, but that's only a small part of the burden of health of illness. Yes, NCDs is therefore a massive focus, and that's coming through in the Manatū Hauora's interim government policy statement, which is kind of the key direction setting document for the whole health sector, and you can read that now. It's out for public viewing. There is also flowing from that, one of the new documents in the way the system's organised is the New Zealand Health Plan. So that's the key this is what we'll do document from Te Whatu Ora's perspective, and that is, I think, coming out in the next couple of weeks. I think it's going to the Minister again towards the end of this week. It must be today because we are at the end of the week. And that absolutely picks up on some of the non-communicable disease stuff. Within, I'll leave Graham in to talk about PHA, and I know that Te Whatu is talking, I think, future session, and NCDs are massive for them. From the NPHS perspective, we have a lot of work and workers within our system that do a lot of their focus is on non-communicable disease, whether it's tobacco control or alcohol policy or advocacy around climate change, etc., etc. So that will continue. We want that to be enhanced because it needs to be. That's where the real gains are. So yep, absolutely. Graham, I know you'll have more to add.
Kia ora, Maria. I do, after having a moment, have a think about it. So thank you for that. Look, what I would want to pick up on is coming back to talking about determinants, wider determinants being a key part of the work program for all of us. And those are very clearly connected with NCDs. So bringing that focus, I think, will be enormously important, recognising, of course, then we also have subject matter experts in the Public Health Agency, and so particular things, tobacco control and the new smoke-free legislation is obviously an enormous part of our work program right at the moment. Alcohol has been signalled really strongly as another significant part of that work program. So the answer is, Rachel, yes, NCDs are every bit as important as communicable diseases, and at the same time also, of course, we do not want to lose our focus by shifting the COVID-19 directorate across this new system from being able to respond well to communicable diseases as well.
We are about to run into the time limit there. I think we've got time for a last quick one from Dufford, and then we'll need to move along.
Kia ora, korua. I'll just have a question around if there was any plans in the pipeline around engaging with other sectors from a data and intel point of view, to allow us to, you know, a better route to collaborate locally.
I'm happy to kick off, Maria. Yes, absolutely. There are already a number of forums, cross-sectoral forums that Manatu Hauora and others engage with, but the intention is, how do we leverage the intelligence and surveillance and knowledge function in those forums, and how do we connect with the data and information in there? So there is some work that's needed in some of those spaces, but the initial relationships actually already exist. For example, kāinga order, justice and corrections, obviously Oranga Tamariki and the Ministry of Social Development. So absolutely.
Okay, Shanti has put a question in the chat, but perhaps Maria and Graham can reply directly to everybody on that one. And I'd like to thank both Maria and Graham for your presentations, much appreciated. And I'm continuing to amaze that the wiring diagrams just seem to be getting more complicated than ever. So well done that you can actually follow where everything fits. So thank you once again, Maria and Graham. Now it's my great pleasure to introduce Laura Cleary, who is the Manager Data Services National Collections Reporting in Health New Zealand. So welcome, Laura.
Thanks, Barry. Kia ora koutou. So my name is Laura Cleary. I manage the data services team, which is in the National Collections and Reporting Group. We're in the Data and Digital Directorate of Te Whatu Ora. So I thought I'd give a bit of a viewpoint of where our perspective is on sort of the data and intelligence sort of ecosystem within health, and then sort of talk a little bit about the wider picture. So national collections are, it's in the name, so national level data collections related to people's use of health services. So we really provide the enabling environment for people to turn data into intelligence. So the good news is that data can be used for to support better health in a number of ways. So data underpins a lot of the things that we want to do to get the evidence that we need to make good decisions. So equity monitoring, understanding health outcomes for different groups and different communities, care delivery and service provision, so providers understand better the needs of their patients. A lot of the stuff around measuring system performance, evaluating systems, policies, programs, planning and program design, all of the work we need to do for surveillance, so COVID very topical, all the data that goes into those 1 p.m. briefings wouldn't be possible without sort of that enabling environment. And then research as well, so ensuring that we're able to share data in a way that protects patient privacy and confidentiality, but also enables people to do the research that they need. But data doesn't just become intelligence. So there's quite a lot of steps you need to go through to take that information and transform it into something useful. So a lot of people ask me, what is the data telling us? And data doesn't really tell you anything. I mean, it can tell you that, you know, Maya Jones had a baby on the 1st of June, but it's not sort of giving you the bigger picture. So I sort of think about kind of 4 pillars around data and intelligence. So the first is data, which is your large databases, spreadsheets of row level data. Every row is an event or relates to a person, and it's really useful information, but on its own, not super useful. So what you need to do is take that data and sort of summarize it together to give a picture of trends, and so people can kind of look at, you know, if you were looking at birth rates, what's going on with birth rates in New Zealand. And then analytics gives you a more in-depth look at that data and says, okay, so we're seeing these trends, but why? Like, what's driving what we're seeing from that reporting? And in my view, intelligence is sort of the culmination of all of those things. So it's a process for transforming data in a way that you use the analytics and reporting together to understand what's driving health outcomes. So both within the health system and sort of the wider determinants, bring that together. And then you can use intelligence to inform your decisions. So you make decisions based on what the evidence is showing you, and hopefully that means better decisions, which leads to better health outcomes and improved well-being. So an example that I thought I'd give is something that I've found quite interesting in the past few years is that you probably all know this, but birth rates in New Zealand have been falling steadily for a long time, but quite sharply in the last 15 years. So we collect in the national collections data all together from hospital events, lead maternity cares, birth registrations. We smush it all together, to use the technical term, into the maternity data mart, and then we use that data to do reporting. So we have online data that people can look at, and in this graph at the bottom left is showing birth rates by the age group of the person giving birth over the last, since 2009. So that's interesting. You can look at the trends, but then you need to sort of get into the weeds of that and analyze that data to say, so why are birth rates falling? And when you look at this data more carefully, you can see that actually birth rates are relatively stable in the older age groups for people giving birth. Where they seem to be declining the most is in younger age groups, and particularly for teenagers, so people under 20. And then what you can do with that analytics is sort of bring it together with other information, and you can see that there's a strong correlation between declining birth rates for young people and access to effective contraception methods, so long-acting reversible contraceptives. So to me, this is quite a good news story, because what it suggests is that young people have better access now to reproductive services, and they're able to make they're able to exert more control over when they start a family. But you might, based on that, think, okay, well, do we need to do some more digging here? Because are these benefits that we're seeing for young people equitable across the country, or do we need to collect more data, do more reporting and analysis to see if maybe there's some communities where there is unmet need for reproductive health services, and maybe we need to target some interventions or put some more funding towards those groups. So there's that sort of the 4 pillars that I see for data, reporting, analytics, intelligence, but data doesn't become intelligence on its own. And so the National Collections is really focused on the enabling environment that allows you to transform data into intelligence. So these are just some of the things that we work on. So data sharing, data governance, making sure that we can share data in a way that protects people's privacy and confidentiality, all the stuff around data quality and standards. So ensuring, you know, going back to providers and saying, you've reported that the 6-year-old child had a baby. Is that correct? Probably not. What's going on? Is it the wrong NHI? Was there a birth date entry error? That sort of thing. And then also skill and capability building. So working with analysts to make sure that they have the skills and knowledge they need to do the work that's required, but also building the skills of people who want to use our data. So if you're a decision maker and you need information to help you make those decisions, how do you understand what the information is telling you, and how do you interpret that? So metadata as well. So a lot of information about what the national collections are, what you can use them for, what you kind of can't do with the data. So you might want to use maternity data to look at maternal smoking. There is information in there about smoking, but it's not very good quality, because for various reasons. So the metadata tells you that you need to interpret those fields with caution. So the good news in New Zealand is that there is an enormous amount of data collected in the health system and beyond the health system. So data is collected in primary care settings and GP clinics from allied health professionals. It's collected in hospitals for inpatient and outpatient at specialist services. There's a lot of notifiable disease data collected. We collect a lot of information about people accessing health services. And there's also information collected about social determinants of health. So the wider environment, housing, the built environment, that sort of thing. And the other good news is that a lot of that data is collated together to give a national picture, which is what we look after in the national collections. So we bring a lot of that data together to curate it in a way that enables research, reporting, analytics, allows you to generate intelligence. And we provide a lot of the enablers around that data, so metadata, that sort of thing. And we also have the National Health Index, which allows you to link the various collections together. So if you wanted to know, for example, the health outcomes of people who'd had a baby, you could then link maternity data to hospitalizations data or pharmaceuticals data to see sort of what happens after the baby's born. The less good news is that not all of the data that's collected in the health system and beyond is sort of curated in a way that enables analytics. So currently, there's a couple major gaps that we're seeing. So one is that health conditions that are diagnosed in a primary care setting. So for example, things like asthma or endometriosis, that data isn't collected together in a way that enables analytics or reporting, particularly at a national level, including primary mental health data. There's missing information around, so the allied health services, so things like physiotherapy, osteopathy, nutrition services, that data isn't really collated together in a way that enables the generation of intelligence. And the social determinants of health, there is a lot of data out there in the wider sort of world about social determinants of health, and you can do some data linking within the Statistics New Zealand integrated data infrastructure, but there's more work that needs to be done in that space as well. So from my perspective, that's sort of where we're going to be focusing for the future in national collections and data and digital. So working on all of these enablers that support transformation of data into intelligence. So more data. There's quite a lot of programs underway around getting more data at a national level. So HIRA, which is the National Health Information Platform, the National Primary Care Program is being developed at the moment, a National Medicines Data Repository. And then within NCR, we're doing quite a lot of work around ensuring that we're doing the best we can with those enablers. So more skill and capability building, more and better metadata, standards for analysts about how to work with data, a lot of tools and software supporting people with commissioning of intelligence and data literacy. So working in that space as well. But we're only one very small piece of the puzzle. So this is sort of my brain dump of all of the things that I think are required to transform data and information into intelligence, insights, and evidence-based decision-making. And this is just also a small piece of the puzzle. There's so much that goes into that pathway. So I think I wanted to say is that it's going to require all of us in the new health system to work together really closely. So we're very nationally focused in national collections, but I can tell you about birth rates at a national level and what's happening for young people at a national level, but that doesn't necessarily hold true in localities, districts, regions. We need that local knowledge and context to understand what's happening for young people in specific places. So it may be that overall young people have better access to reproductive health services, but it might not be true in a specific area. So we need that local knowledge to target, to understand where we need to target funding and resources. We need community engagement. We need a lot of cross-sector working, data linkage, working across the health sector, but also with the wider sort of data world to understand the wider determinants and social determinants of health. So there's a lot of stuff in here. So I just wanted to make the point that I've got this little piece of the puzzle that we sort of focus on and work on, but there's a much wider context to that bigger picture for transforming data into intelligence. And within this new health system, hopefully we'll be able to work together in a kind of concerted way to get the data that we need to make the decisions that we need to make. Cool, so that's me. I think there's time for questions.
Thank you, Laura. One comment is that I think that what you've described is a university researcher's delight. All the data that somebody else is collecting that we don't have to pay for to collect, and the ministry is going to do all the hard work for us, and we can get to write the academic papers out of your hard work. That's the way. But I do think that one of the things that the tension there is that you're collecting the data and providing the tools, but I think it's the bit that PHONZ is particularly focused on is who are the bods that are actually going to do all the thinking and what. And I think that's the tension I see in what we've got here is that we're building wonderful platforms and things, but it's who's going to do the end bit and help and use the wonderful data that you've got. And I think that's the challenge for the health system in the new environment is where are all these people coming from? And you know, there's not a lot of people with that sort of skill set around. So there's a challenge. But I know that Vanessa, you had a question for Laura.
Yeah, look, I've just written it in the chat box, but Laura, look, thank you so much for the tremendous work that you do for our whole country. Those national data collections are, as has the comment directed to Barry, are absolute gold. But as those of us who've used the data collections are aware, you really do need to know what you're doing with them in order to get the most out of them. And absolutely agree with Barry that we need to be working collectively to increase our capacity and capability in terms of actually doing justice to those wonderful data collections. My specific question though was around actually making the outputs of analyses using linked data available and putting that data back in the hands of clinicians to action. So action the data. And I guess the reason I'm thinking about that is twofold. One is in terms of closing the data quality feedback loop. One of the earlier comments was around the quality of the data. So obviously potentially getting information verified by key individuals may be a relevant part to that. But secondly, actually providing the information to clinicians so they can act on it. One specific use case scenario I'm thinking of is some work that was led by my wonderful colleague, Sue Wells, who's an associate professor here at Auckland Uni, as well as being as a clinical director at ProCare. And one of the pieces of work she led was looking at discrepancy and understanding about whether individuals had a history of cardiovascular disease, depending on whether you looked at data from the NMDS, so the hospitalisation data, versus whether you looked at what was recorded within the primary healthcare record. So I guess what I'm really interested in is, you know, what's in place in terms of closing those feedback loops, making the information actionable, and also helping us to ensure that we're continuously improving the quality of the data so that we can help our patients and you know, improve the quality of our services for them.
So I guess we do have a data quality team embedded in national collections, but the thing is that we can't actually see primary care data. So I think that's one of the key things is we do data quality work on the data that we do see, and we do go back directly to providers to do that quality checking. So that example, if you know a 6-year-old child looks like they're having a baby, is that actually just a data entry error, that sort of thing. But I think hopefully the two programs that I think are probably most relevant are HIRA, which I'm not sure if people have heard about, which is this National Health Information Platform, which is, I don't want to go into too much detail because it's not my area and I only know about things from what I've heard, but it'll allow patients to access their own health data, but also the clinicians, so they'll be able to see sort of what we have on record for that person. And then the other side of it is the National Primary Care Data Program, which will hopefully give us more visibility of the data that's available in primary care that clinicians can see as well. And I'm really hoping that as part of those two programs, there'll be an integrated data quality program. And we always advocate for data quality whenever people ask us our opinion when they're sort of designing these programs. We say, you know, data quality is a really key thing. And, you know, I mean, one of the things that we see a lot is, you know, the virtual diabetes register is sort of an amalgamation of national collections data to indicate whether somebody probably has diabetes. But when you actually go back to clinicians at a patient level to check that data, there's often discrepancies, as you described. So I think there is work to be done in that area. and hopefully that'll be brought in as part of these programs that are underway. Yeah, I definitely agree with you. And in terms of accessibility of the data to clinicians, so I think HERA will be the platform that will allow that. So clinicians will be able to see what data is held on record for that specific patient. And then my team do a lot of sort of dissemination work. So we publish a lot of our aggregate data online. And once these new data streams come on board, we'll definitely be wanting to extend that work out to that data to give people access. But in terms of clinicians, maybe there's more work that needs to be done to ensure that they've got better visibility of the data that we have for patients and can sort of have that data quality feedback loop. Yeah.
Thanks, Laura. Ricky.
Actually, Barry, can I just quickly just make one comment? When I was talking about data quality, I guess it's in terms of absolutely acknowledge all the amazing work that Laura and her team does do in terms of data quality. And I guess what I was sort of thinking about was in terms of actually what is relevant information for the person who's wanting to use it. And actually, I guess that's another important consideration when you're using the data for research. So obviously, Laura's team is concerned about the accuracy in terms of, say, the hospitalization event, but sometimes what happens is that the information you need is not necessarily specifically relevant to that. And I guess it's about when you're using data for a secondary purpose, there are additional quality parameters that you need to consider. Just wanting to make that additional point.
Okay, thank you. Ricky, you had a question, last question from Ricky.
Oh, kia ora, Laura, can you hear me?
Yes.
Oh, kia ora. Thank you very much for your presentation. I also had a little question on, well, it's not little actually, I think it's quite a big one, on ethnicity data quality or data quality. You know, like ethnicity data is absolutely fundamental to understanding and addressing Māori health and ethnic inequities in our health system. And I know you've done a little bit of work on this, and Melissa McLeod's going to be talking about this in a bit more detail next Friday in this forum. But there's still a really quite substantial undercounting, systematic undercounting of Māori in health data sets, which is not only important for monitoring, but it's actually important at the individual level for targeted health services. So I'm just wondering if there's any I guess, prioritization for ethnicity data quality happening in the sort of new health reforms?
Yeah, that's a really good question, Ricky and Melissa. I saw your written question as well. And I mean, you're right. It is ethnicity data quality is a big thing that we're working on. So I think the first thing is we've done a lot of work in this area. So myself and other people across when we were all together in the ministry. So the first thing to say is that people who identify as Māori in other contexts, for example, when they do the census, don't always identify as Māori in the health system. And so that could be a data quality issue in terms of the way we're collecting data, but it could also be a person's individual choice, because ethnicity is a self-choice. It's your own identity. So if you choose not to identify as Māori to the health system, that's not necessarily a data quality issue. That's a more systemic issue about why people maybe make those choices. So I think the first thing I wanted to say is that we have talked a lot to the folks at Te Aka Whaiora about this issue. And my personal view is that what we need is some more qualitative research to understand the drivers for why people choose to identify in different ways in different contexts. So that's the first thing. The second thing to say is that we have done extensive work in the health system over the last few years to improve the quality of ethnicity data capture. So there's the HISO standards now for ethnicity data quality. We use the Stats New Zealand standard question for collecting ethnicity information. And there's a lot of tools that have been implemented to monitor ethnicity capture in hospitals settings. So I can provide more information for my colleagues who know more about that. But the work that I've done has definitely showed that ethnicity data quality is improving immensely in the health system and has been for the last 5 years. But I think that the bigger issue is, and I'm loath to make a comment about why this is happening because I'm Pākehā and it doesn't feel like my comment to make, but you know, if there's systematic racism that's happening in the health system, that means that people feel less inclined to identify as Māori in the health system. I think that is research that needs to be undertaken to really understand why people choose not to identify as Māori in the health system. And that's something that we continue to monitor. So I do a lot of work in the IDI comparing the ethnicity that we capture on the NHI with how people identify their ethnicity in the census, and I'll continue to do that each census year. And that data is available if people are interested. So does that answer the question?
Yeah, sort of. I mean, I think that's possible, but actually I think that the evidence over the years have been more around non-adherence to the ethnicity data protocols. And there's quite a lot of evidence that people have, research that people have done. So, I mean, I think I'd just be careful about framing it as somebody's individual choice to not identify as Māori. I guess that's a possibility, but I also think you need to think about maybe the system and how well people are adhering to data protocols. And that should be part of our, quality, ongoing quality assessment.
Fully agree with you. And there is a lot of work underway in that space about monitoring the adherence to the HISO standards. And I can get Stephanie to get in touch with you about that if you're interested, because she does have a lot of information about that space.
I think that's where we'll have to end this. Thank you, Laura, for that. Good oversight. And there is a couple of questions in the chat that are directed to everyone, but specifically you, Laura. So if you can have a look at those and perhaps reply to those questions, that'd be great. So thank you once again, Laura, for that oversight. It's very much appreciated, and just shows how invaluable the work that you and your group are doing as actually the foundation for our intelligence system in the country. It's my pleasure to introduce Dr. Chris Galloway, who is from Massey, and he's going to talk about artificial intelligence in public health.
That's right, Chris. I'll delay you just one more minute. So if anyone does miss the opportunity to ask a question to a presenter, I'd like to highlight the Q&A feature in this webinar. So if you've got a question but you don't get a chance to answer it, have it asked and answered, drop it into the Q&A menu, which should be down the bottom of your screen, and anyone who's tagged as a panelist, for instance Laura, can see what a view item there, and they can type their answers to it in their own time. So don't worry if you miss your chance during a presentation, you are going to get to ask all of your questions.
Thanks,
so Chris, take it away.
Thank you very much. I would appear to be all that stands between you all and lunch, but I'm not a public, like you guys, I'm not a public health expert. My field is public relations and crisis management, reputation management, those sorts of things, but I've also been involved with Barry in talking about the communication aspects of public health to students in the Wellington-based public health system. What I have been doing is writing about communication and artificial intelligence, and doing that from this perspective not of a data scientist, which I am not, and some of you obviously very much are, but of someone, and I'm doing this work with colleagues in Australia and the US, who is looking at the whole perspective of what's happening with AI, with artificial intelligence, and trying to work out what the implications are for the operating landscape, not just looking at individual implementations, although I am going to talk about one of them. So, can you see my first slide there? Patrick, is the slide showing?
So it is showing, but we're getting some people asking if you could put them onto full screen.
Yes, of course. Full screen on, hang on 1 second.
That's it.
Right, there, here we go. So a slightly tongue-in-cheek title. And I do want to thank you for hanging around to be with us for this. So when people think about artificial intelligence, there's a sense that it's all about robots and the automation of things that human beings are not very good at, and those would seem to be quite a few things. And many of us will know, maybe all of us know, that increasingly artificial intelligence or AI is being used to review data. We've had a lot of discussion this morning about analysing data and assessing its significance. But as they say, wait, there's more. And a homegrown example of that is this company, Toku Eyes, based out of the ophthalmology and optometry section of Auckland University Medical School. What they've been doing is working with diabetic patients, and they've developed a suite of AI-driven systems, working with retina scans from these patients to identify prospects for preventable blindness, and also now cardiovascular issues, the risk of those issues. And their system allows such identification to happen within 10 seconds. And the system that they have, excuse me, is so sophisticated that it doesn't require setting up in a hospital environment. In fact, it is sufficiently simple to install and operate that they have told me that it could be set up in a pharmacy or an optometrist clinic. And so here's a homegrown example of an artificially intelligent startup company, actually, that is using its technology to contribute to the whole public sector health system. It's doing this also just by way of interest in India, and is seeking to break into the American market with this technology. So we could spend all day talking about what artificial intelligence might mean for public health intelligence. But let me just ask the question, are we facing ultimately a situation when robots of different sorts, artificially intelligent systems will take over? I'm not a believer in what some people call the singularity, that we will reach a point at some stage where such systems will take over and we will serve them rather than they us. So I don't think that's a realistic prospect for the reasons given on this slide. That powerful as AI is, it can't completely replace the nuanced judgment that we all can bring to public health intelligence and other forms of decision making. That's actually an interesting subject for discussion, and one of the big areas that I don't touch on this presentation, but I have an 800-page book here at home discussing is the ethics of all of this. Artificial intelligence and ethics, but I want to introduce you to the concept of extended intelligence. This, despite the picture, is not about creating bionic humans. It's about the idea expressed in this next slide, which is talking about the blending of AI technology with human intelligence. So it talks about the symbiosis, if you like, between AI and human intelligence and vice versa. And this is something that has come out of the work at MIT in the States and is ongoingly being developed by them. So it's a relatively new concept, although people have talked about augmented intelligence for some time. This EI, or extended intelligence, is a relatively new take on all of that. So how could extended intelligence help us in public health? It's already been shown in overseas research that AI systems and human beings working together can be more effective than either working alone in detecting malignancies in chest radiographs showing up there. So how can all of this technology help us? Well, I've suggested 3 points there. Validating human interpretations of data. So we know, we've talked about big data this morning, that AI-driven systems can very quickly crunch numbers. We still need to have the human interpretations of them rather than relying on what the system itself says to us. It can generate wider fields of options for clinical interventions, and I would suggest to you facilitate more effective intelligence-based public health communication. In other words, these systems working to extend human judgment, human intelligence, can help us do a better job of looking for what some people call the signal in the noise. That's a very quick canter through what is now a vast field. I'm very aware that it's very shortly to be lunchtime. But I do want to suggest to you that we need to be having conversations about AI from the perspective not just of looking at and using specific systems as Toku Eyes is doing, but also to look at the broader perspective, which will be enabled by the various agencies and teams that we've heard discussed this morning, as to the overall changes happening in the operating landscape for public health. So I think I've done my dash a little early, Barry, but I'm very happy if anyone wants to raise a discussion point. I stress I'm not a public health expert, except insofar as when it comes to health, I prefer to be well rather than not. But I really think that we should be stimulating discussions in the public health community about what these technologies mean now and for the future.
Thank you, Chris. And I certainly think that you've got a wonderful lunch to look forward to. One of the advantages of having an online conference is that you don't actually have to provide lunch or any other facilities for that. Any questions? I see that, Vladimir, you've got a question. You there? Could you stop sharing your screen? That's good, Chris. Yes, Vlad, do you want to ask a question?
It's rather in order of supporting that. Yes, AI very important, but what I wanted to say that numeric and technology literacy can be very competitive to the involving AI technology, especially if to consider from point of view of effectiveness on dollar. So I would put them even together. So yes, they move to AI area and numeric and technology literacy.
Spasibo, Vladimir. I agree with you. And all that one can do in a short presentation is just touch on a few aspects. There are think tanks around the world looking at the implications of the technology and the different streams of work for one and the different fields that one can bring together when one is considering AI and all the ramifications of it. And you're right, numeric and technology literacy are part of that whole picture. I see that there's a question there. Are there any public health intelligence examples of AI and machine learning applications in New Zealand? I would suggest that that could be a fruitful question for researchers to follow up on. And certainly that's something I'd be interested in seeing happen. I'm not aware so far, but I do see, I collect this kind of information, and I do see almost every day examples from around the world being presented.
Any other questions? So Chris, just to recap, it's not all machine driven, it's actually machine and humans working together to solve the problem.
That's what I'm advocating. I think that there has been perhaps too much emphasis in certainly in the popular discussion about AI, on the prospect of AI-driven sessions and systems rather, taking over completely, with human beings being driven by the findings of smart systems. This is, if you like, an attempt to redress that imbalance and say we still must have humans in the process.
Robin Whitaker has replied to Chris that there are examples. Perhaps Robin, sometime you might be able to put those on chat room or somewhere and let her about the work that you're doing. Anybody got any other questions for Chris or the other presenters are here? Well, thank you everyone. Thank you for participating in this, the first session of PHONZ. I think it's been a wonderful start to the 3 mornings, or 3 mornings and a bit of an afternoon. Thank you to all the presenters. And we'll break for lunch. Unfortunately, it's a self-catered lunch. PHONZ, this is free, so you have to do your own catering on that one. And we'll start again at 12:40 with the first speaker, which is Ron King from AFS in Auckland. So once again, thank you to the speakers and to the participants, and we'll see you at 12:40. Thank you.
Yes, and a last bit of admin before you go, a couple of outstanding questions. One for Laura, which you'll see in the QA menu about National Collections. Unfortunately, Graham and Maria have had to leave us. So Alison, we see your question. If you like, we can pass that on to Graham and Maria for you.
Yep. So keep the questions coming in, and we'll see you at 12:40. Thank you.
Barry, did you just want to explain your slide that you had up just before, or is it there just as a placeholder?
It was just there as a placeholder. Yeah, I can always put it back if somebody wishes to see it.
Hey, Ron. Yeah, so we've had a pretty amazing morning so far. We've had some absolutely wonderful speakers, and we've got further wonderful speakers this afternoon, with Ron King kicking us off from ARP. So Ron, the floor is yours.
Thanks, Tim. I'm going to go straight into a screen share, I hope. Right. Everyone see the picture?
Yes.
Right. Kia ora koutou. I'm Ron King from Auckland Regional Public Health Service. I'm going to take you on something of a whirlwind tour of public health intelligence as it's being developed and operates within the Auckland Regional Public Health Service. In case some of you don't make it all the way through my session, I'll give you a spoiler that public health intelligence in a public health service is, I see it as a whole of service function rather than a simple data analytics kind of team function. So what are we going to go over? First, I guess I'll give a quick overview of the scope of work covered by AFS, or public health services generally, which really does necessitate general public health intelligence capability. Then I guess I'll be providing overview of the formulation and application of public health intelligence via 3 different frames of view: processes, information, and knowledge application. So we'll kick off into what public health units or public health services like us have traditionally done. So we cover an extensive range of services and activities. Now, some of these are planned, but many are responsive, and even some of those that look like they ought to be planned are actually quite responsive and require pretty rapid turnaround. And this necessitates a capability, a readiness capability, and more than that, an ability to deliver multiple simultaneous activities using a intelligence evidence base to make decisions and action, make the right actions. So going through from a kind of a team structural angle from the organization, first up we've got the environmental health team, and they deal with environmental events and exposures, and this can be toxic fires, Legionella outbreaks, mosquito interceptions, lead poisoning. We've done 1080 bait clearance audits in public parks. It's a really broad set of activities that team undertakes, hazardous substances and the like. We've got the health improvement team, which is very much around those longer determinant focus things, active lifestyles, harmful commodities, urban design, food environment. And so that on the one hand, it's quite a different focus from the communicable disease and environmental sort of exposure view, but from as I guess I'll explain, at a very general level, there's the same kind of processes and application of public health intelligence required to deliver those effectively. And then we've got the classic communicable disease, which takes up traditionally a lot of the focus and air when we're talking about public health intelligence in the sector. We've got the classics, tuberculosis and measles, rheumatic fever, and of late we've had a few novel pathogens and been busy even the last week or two with monkeypox. Last week, I didn't have that much foresight. So effectively working across all of these to deliver public health intelligence to enable service actually requires an understanding that these involve multiple processes at multiple levels, multiple teams. And I guess that's the kickoff of how we frame and understand public health intelligence within a PHS. So a number of, I guess, public health processes. The first is an ongoing process, whether we're aware of it or not, and that's things going on in the community that will affect future health states across the community. So that's both determinants, longer term determinants, as well as immediate risks around notifiable disease. And when we talk about community in this context, it represents both the population at risk and the context in which this process is occurring, the fabric of these communities, the physical environments in which they occur. And this is where we have inequities and so forth, and that can be applied to explain the differences and the observable events of this process. And you really need to be able to pack in those wider contextual issues into any intelligence service. So it's not just about a focus of notifiable disease processes and operating on them and doing your case and contact management. You need to understand the context in which this is all occurring within a community that you're trying to protect or enhance. Then we've got the detection process. So what level of awareness do we have of this disease process or risk or health process? And the classic ones are around lab notifications of notifiable disease. But there's also a kind of a range of identification or detection processes. We can be alerted to a toxic spill or a fire by the fire service. Members of the public alert us to various events or ECECs, or early childhood centres, around enteric disease outbreaks. And So we need to identify those processes where they may be undercounting what, how effective they are. Then we step down to the operational processes, which within the public health service generally revolve around the notifiable disease. We've got these case and contact management systems within us. We've been running around NDCMS, notifiable disease case management system, for over 10 years, and that deals with the measles and the tuberculosis and so forth. But there are other operational processes depending on what we are handling, and those even can be outside the remit of public health. So other services may be running operational services processes around their activity around an exposure event and whatnot. And so it's having some understanding of that is really important to be able to interpret what the data is and what you're doing with it. And then we can drop down to the informatics process of what systems, understanding the systems people are using operationally, and how that data is collected, and the data models behind it, and then being able to interact with those to make sure that they're serving both the needs of the users and the operational processes, but also those high level requirements provide information for analytics up through to an intel level. And through all of these detection operational informatics processes, there are a whole range of decisions that get made. It's not just at the high level strategic end of public health, where you have a number of leaders in a room making decisions about your strategic requirements or control strategies around an outbreak. Each one of these processes has key decisions that you need to be aware of and potentially even interact with and influence from an intel perspective to deliver effective services. Obviously, these processes can change quite rapidly and they're quite dynamic. And so maintaining the relationships and understanding of these is really key to delivering over any time period, really. In terms of the operational processes, we commonly go through multiple phases during an outbreak, from a keep it out, stamp it out, manage it. And that can change the meaning of data and what's collected over the course of an outbreak. And so naively trying to interrogate systems without having that awareness can lead to substantial misinterpretation and of that information. Information management. So there are a number of systems that exist to provide operational and surveillance activities for public health services. And I've mentioned NDCMS, our internal one. There's FESERV, the National Surveillance System, NCTS, currently COVID going out to measles. There's national collections. There are a whole range of systems that we can, or data we can access and interact with. But none of these provide the type of integrated capability required by public health intelligence to enable a service to do the work it needs to do. So over the years, we've developed a pair of systems, effectively Verrall and Sisyphus, which are, for want of a better word, are information assemblers or information management systems. I tried to run with the name Sisyphus, but wasn't really that popular as obvious. It's a little too close to syphilis, which we also run, so I'm not sure it's going to take off, but I thought it was quite entertaining. So Verrall is the notifiable disease flavor of these systems. It's very secure, very restricted access to the store because it has identifiable information around the case and contact management systems, whereas Sisyphus works much more across, or entirely across, the health promotion and environmental health thing, where we're talking about built environment or environmental exposures, and it's not around individual records. And the impetus to build these was really recognition after experiencing having to manage all that scope of work with a team of, started with one, and really the desktop and manual processes we just couldn't cover that scope of work and deliver effectively to enable our service to function. And really, you're looking at death by 1,000 spreadsheets if you're trying to manage these by extracting data from these systems and then have a team of analysts working through them. And I'm not going to go through the system's objectives on the right, but that way of working introduces a whole range of issues around security and error and inability to audit or log anything that works off desktop applications where you're doing that data management and transformation and changing things as you go. You really need to work that through an auditable, traceable system that enables you to be able to repeat these activities over time. As I mentioned, that system to be able to cover these various, the large scope of work needs to be able to suck in information from a very wide range of sources, both from within and external to the health sector. So we've got a national collection data, we've got notifiable disease data, but we also need to be able to pull in the things around the built environment, liquor licenses, cooling towers, residential institutions, and then we've got climate, daily meteorological conditions, land use, demographics, administrative areas, inbound flights we might want to scrape, school calendars might be of relevance. And these all need to be pretty much automated or triggered to enable a timely and state of readiness to apply this data store to any situation that we might occur. And
Thanks there, right. I just thought yeah, there goes the bell. We've hit your 15 minutes.
It's going to get quicker.
We're eating into your question time, but if you want to finish up.
I've got one more slide and then we're done. Sorry.
Go for it.
I wouldn't say it's big data, it's medium data. We don't operate in the big data manner. So this, you might have noticed that we're really talking about not intelligence here, it's just data information. Where the intelligence comes within a public health service, public health systems like Serval enable an unbroken thread. So from the source to the outputs, we can track it, we know what it is. But those processes I mentioned earlier, where we harness the domain knowledge from a number of processes, and that really enables the application of intelligence to the thread. General public health intelligence capabilities isn't bolt-on. You can't parachute someone in. It's the ability to assemble an organization like us, expertise to the greater whole. And that's where the people come in. So it's not a data process, it's a person process. And I'll wind up there.
Wonderful. Thank you very much, Ron. That's a very insightful presentation about apps. I've got one question for you from Mike Keenan. Is there a need for a server-side, MPHS server-side infrastructure that could be shared across MPHS, Windows desktops, poor environment for analytics?
Well, I can't speak from the national view, but everything we've built is potentially, the technology is shareable. We have built on an open source platform. We use Postgres and R, and we're increasingly using GitHub to be able to share the scripting and the automation side of it. And we've done so effectively in the COVID with other agencies to date. But really those data structures and the standardization of those and the application of methodological standards is really key to enabling a coherent and consistent method. But that's just the data side. Yeah.
Yeah, I totally agree. There doesn't seem to be any other questions. I've got one for you though, Ron. ARPS being obviously spread across multiple district health boards, what's been the key to make sure that you're sort of being collaborative between the different DHBs?
Relationships. It's people. It's always people. Understanding each other's needs and how we can interact and what the relationships means to deliver our respective goals and missions, and come across that, and the gateways get opened. I mean, we still have barriers from time to time, but those are reducing, and COVID was a huge enabler of that, to say we need to work together. And so a lot of our capability is now getting increasingly integrated into the regional systems and working across the DHBs much closer than we did. So we've got access to the hospitalizations and labs and so forth, which was really more difficult earlier on.
Sounds like a lot of coffee dates and networking. Barry, you've got a question.
Oh, you're on mute.
Not like me. Some people think that's a good idea. One of the things that I think is really important in what you just said in response to Tim's question, Ron, is that it's actually about relationships. And I think that the problem that we've had, and dare I say it, a problem that's potentially could happen again, is that the public health intelligence function, and therefore the workforce, tends to get walls put around it. So you're responsible for the Ministry of Health, Public Health Agency, and X, Y, and Z. And in fact, it's actually about us, the workers, the doers, that actually make it work. It's not who you work for. And I know when we were steering group was setting up PHONZ, the one thing that we did say is that we needed to get in before they actually put the walls up around organisations. And I think the very thing that you mentioned about Auckland is it's actually relationships amongst the people that do the intelligence that actually is the critical bit. It's not the fact that you might be in the Ministry of Health or X, Y, and Z, because as and even the Minister said, this public health intelligence capability is very limited, it's very fragmented. And when you look at those slides that Graham and Maria put up, it potentially become even more fragmented because you'll be reporting for various things. So that, I think, is the huge challenge that we've actually all got, is to basically kick the walls down and say it's actually about people.
Yeah, I totally agree. Thank you, Barry. And thank you, Ron, for your presentation. Our next presenter is someone that I've heard of, but I've never met. Heard of good things. It's Dr. Richard Hoskins. Go for it. The floor is yours.
Kia ora, Tim, and kia ora koutou, everybody. I'm just doing the screen sharing thing. Hang on a minute. Let's share that and put the presentation up. Much better than looking at me. Come on. Yeah, there we go. Now, my apologies to everybody that I've plagiarised, starting with the Spice Girls and going much further forward than that. And just as we are in the post-lunch period, just make sure people understand that only the last slide is important, and the others are just a smorgasbord of stuff that I've either done myself or plagiarised from other people. So I'm a medical officer of health in Waikato Public Health Service. I learned earlier on today from Maria that we're going to be called Public Health Service, not the Public Health Unit, so it's already been a valuable session for me. I have previously worked in multiple other public health services, including Auckland Regional Public Health and with Ron, and I've definitely plagiarised some of his and other people from theirs work. So this presentation, I'm starting with a disclaimer, and that I haven't been an analyst in the public health area for more than 25 years. I did start my public health career working as an analyst, initially in the resource utilisation system, then in the Midland Regional Health Authority, and for a while for Richard Hoskins Consulting Limited, who deigned to employ me when the ministry finally made me redundant. And I once wrote a report recommending the arrangements for analysis, intelligence, knowledge and wisdom when the RHAs were being transformed into the Health Funding Authority. That report had absolutely zero impact. And I can remember some of what I said, and not much. Having said that, I have worked with some excellent analysts over the years, and I continue to do so and highly value the work. As a medical officer of health, I like information and evidence that supports what I want people to do. So there's a clear conflict of interest there, in that I don't want the information to tell me what to do. I want me to have the analysts give me information that persuades people to do what I know is best for them. So apologies for that. And of course, I'm wrong. There are also many medical officers of health in Aotearoa who are much more info savvy than me, including the new Director of Public Health. So that's very reassuring. The jargon I use will of course be outdated and inaccurate, and effectively this is an invited presentation, so you need to remain nice to me throughout and in the question time. The purpose of this one is to reinforce and possibly expand what you know about public health services, or at least this medical officer of health in a public health unit, what you know they might want from you. And I'm going to start that off by illustrating it with examples from my particular responsibility areas and experience. In the Waikato, we divide, well, we cover everything when we're on call, but we of course have areas of specialty that we look after, and you'll see mine on the next slide. We are only, of course, one of the users and clients of the health information that people in the public health information sector, which is incredibly broad, put together and disseminate. Health information is not the only influence on decision making. Something beginning with P is another very important factor that we won't be covering here. So as I've said, in my public health service, each of the medical officer of health works leading various portfolios, covering the range of things that Ron talked about: communicable disease management with talented and influential colleagues, environmental health, social and regulatory issues, trying to influence policy, health promotion and improvement, and being added the population health issues of screening and immunisation, which have largely been in other parts of the organisation of the publicly funded health sector in Aotearoa up until current times. In my portfolios, I cover some social issues like alcohol, tobacco and vaping, cannabis and psychoactive substances, refugee and migrant health. I am assigned as the medical officer of health with our health improvement workplace setting team, and my communicable disease portfolios. Measles has followed me around for the last nearly 2 decades now, and also I cover the other things in that vaccine, plus TB, leprosy and whooping cough. The two with an asterisk, alcohol and measles, are the two that I'll give you some examples of the sorts of health information and intelligence that we use to influence our and society's response. So first of all, starting off with alcohol, there are mandated responsibilities under the Sale and Supply of Alcohol Act 2012, which one of its 2 objects is harm minimisation. The other one is reasonable access to that toxin. And that means that we must report on licence applications to the local decision-making committees. We must be consulted on by local government with respect to forming local alcohol policies if they want to do things differently than the national default conditions. And we must collaborate with the other statutory agencies, police and the district council inspectors, on monitoring, including controlled purchase operations. Don't you love the acronyms in here? But in addition to that, we do policy work, and mine has been largely building outrage to the conditions in the current Sale and Supply of Alcohol Act, which are not nearly transformative enough if we really want to change our relationship with alcohol in Aotearoa. And also working with our health improvement teams, if that comes up as something that a setting they're working in detail with wishes to be supported to address. So with our licence applications, we have to report to local committees on the effect of that licence in the local area, and we try to present them with harm data. I'll show you this next slide some work that we've done locally on making alcohol attributable presentations to ED influential in our reports and in the decision making of others. We are continuing to work on alcohol attributable admissions, and we will soon add that to the suite of evidence we add to our reports. We take information directly from our police colleagues and use that, and we also talk about this notion of amenity and good order. We add in density and proximity information, and we talk about vulnerability or deprivation. So this is a ClickSense database that the Fed and his team have put together, showing alcohol attributable admissions by date over the course of the 2 and a bit years now that we've been collecting meaningful data from our EDs. We've been collecting data for a long time, but that kind of yellowy line, the unknowns, was at around the 97% mark up until it was made a mandatory choice in our local databases. And the panel on the left shows a number of the areas that we can drill down into. And if we're looking for even more specific information, we will, my alcohol delegates will work directly with our Intel team to put together more local information. This is an example of that, showing the people who have presented to alcohol with involvement in relationship to the state highway that runs from Tamaki Makaurau through the Waikato and is one of the major drivers of morbidity and mortality from road traffic crashes in our region. And I'm not proposing to go through the detail, but this is the sort of information that we present to the decision makers when we don't want them to license the first alcohol takeout shop at a new service centre being built on the Waikato Expressway. We think it's a silly idea to have McDonald's, and we think it's a silly idea to have McDonald's, but that's a different story. But to have multiple food outlets and a gas station and the other outlet being a bottle shop, it just doesn't seem like the right thing to do to us from a harm minimisation point of view. So we present this sort of evidence to our decision makers about licenses, or we present information. This is a heat map of deprivation in a southwestern bit of Hamilton City, and overlaid on the health map are the existing outlets and some sensitive sites such as schools and so forth. And we use this information to try to convince people whether or not there should be a new or renewed license there, and or to convince the person applying for it to withdraw their application in the first place, which is what happened with this one. Great outcome. Well done to my team. And then just another version of this. This is a proximity map where the red circles that merge within 1 kilometre of what's of an outlet, and it maps what the sensitive sites are. So information to try and persuade people to make sensible decisions. And this is another version of the same thing when again somebody wanted to produce a third outlet in close proximity to others. I don't think we prevailed in that one. I think that was their local politicians who didn't want it either, which is always good. Next example is measles. My colleagues are convinced I have a viable vial of this, and whenever I'm about to go and leave, I go out and sprinkle it in an area where there's somebody who's likely to be susceptible. Because the measles outbreaks, epidemics do tend to follow me around, and my apologies to my colleagues about that behaviour of mine. For measles, we want all the usual stuff, epicurves, the demographic breakdowns and distributions, etc. Plus, over the years, we've come up with a few additional things which aid us in our understanding of the outbreak, aid our communication about how an outbreak is progressing, so that we can be more effective, and that aid our responses to trying to avoid future ones. The first is what I call my network chart. which I also did one for the first wave of COVID and then the Delta wave. You have to abandon these after something gets up into high numbers, but in the very early stages, these charts are incredibly useful for understanding and being able to explain how something has spread. So simply as you run your eye from top to bottom, this is a week at a time, illustrated by the dotted lines, and as you run from the left-hand side across to the right-hand side, this is where the cases came from. So it starts off with imported cases under the aeroplane. Imported cases are almost always returning New Zealanders rather than tourists. And then runs to cases that have spread within your district, and you can add little colour codes for genotypes and solid and dotted borders for probables and confirmed, and so on and so forth. And this is a couple of outbreaks that happened in the Waikato in late 2018, and then the one and it spread from Auckland in 2019. We find these really useful for explaining, particularly to our local health sector and media, in terms of how something spread, and it gets our head around it as well. So we you can't predict where it's going to go next, but you get a really good feel for that. We used this sort of tool with the Delta outbreak, well, first of all, the initial Wuhan strain and then the Delta outbreak, and it was incredibly useful for illustrating the communities that COVID was in during that outbreak and how the interrelationships and how it spread. And we were able to show that we actually stamped out Delta in several geographic areas within our vast rohi. Well before Omicron took over and finished off the stamping out job. I would love for there to be an automated tool for this, and one of my colleagues at Waikato has initially drafted one of those, but we didn't take it any further. So this is just drawn basically freehand using Visio Basic. Apologies for the hinky down-home nature of it. And it is relatively labour intensive, but network charts are really useful. Now, this one is the one I need to attribute to Ron, and it's a video. I'm just hoping it will play for me. Look, it did when I practiced. Here we go. So you will see little dots appearing. This is measles in Auckland in 2014, not the big outbreak while I was there, which was 2011-12. But it shows how it spreads. And if it's a blue dot, it's an epi-linked case. And if it's a red dot, it's not. And you can see it progressing as we go in terms of showing how it spread within local communities. And this chart was particularly helpful in working with our colleagues in primary care around really kind of galvanizing some of the responses that primary care could take in those areas. So early on, there was a big North Shore of Auckland cluster, all linked. So a really nice visualization that I found very persuasive. These are just our surveillance, routine surveillance charts. This one does monthly cumulative information by year for the current year and the previous three. Thanks to Bruce Adlam at ARFS who first developed these, but I know he's gone on to much more clever things than this. And this is the same thing, just presented as weekly data and using standard deviations to set warning lines to show us whether we might be. This is much more useful for something like salmonellosis or something that occurs relatively frequently. I mean, any measles case is an epidemic, but it's a standard set of charts. And the last example, and the second to last slide, so the next one is the one that's actually important, is some graphs that we put together in the Waikato using information from 2 of our 3 primary health organisations on the documented MMR status of their enrolled populations, which covered more than 90% of the enrolled population and was able to be used to highlight this time for the age group 15 to 29, but where our biggest immunity gaps were and whether they were of a first MMR or second MMR nature. Really useful in informing what we tried to do during the 2019 epidemic with prioritising the limited supplies of MMR, or at least trying to, until we were told not to do that it was racist. And now the important slide is these are the things that as a medical officer of health, I really value working closely with Intel people on during these sorts of issues. I love predictions, but as the Danish politician said back at the turn of last century, predictions are really difficult, especially when they're about the future. So in lieu of being able to predict everything accurately, what I want and appreciate in analytic intelligence work is that it's intuitive. So you work out what I need to know before I need it, or before I know I need it. It's nimble, it's able to switch quickly to prioritize and adapt to my ridiculous expectations, and it's fast. So it might not quite be the future, but it's certainly almost real-time present. You know, when I need it now, and I really want you to do that for me. So thank you, everybody, and I think I've left a little bit of time for questions.
Yes, thank you very much, Richard. It's wonderful to see your infographics, and it's a classic example of public health in action. We can open the floor to maybe one question if we've got time. So we've got one question from Giles from Public Health South. That's, he says that they had a tool developed that drew on NCTS data, but unfortunately they never got to use it in the field before the Omicron outbreak. So it'd be interesting to know a bit more about that, Giles.
I remember, I don't think it was Giles, but a registrar who was working in Public Health South who made contact with us about the network tool and might have done a little bit of work with Alex, who was our public health medicine registrar working with the FIT team initially on using either our network tool or further developing it. Yeah, so definitely this work. We built ours, our network tool that Alex built in something I think called Python or something like that. He'll correct me because he gets to talk later. And it drew on data that we had in what we called our master spreadsheet, which was one of Ron's death by 1,000 spreadsheets that we used during Omicron, during the Wuhan wave. But we were able to populate that with data extracted from NCTS as you know the systems developed.
Great, thank you very much, Richard. Wonderful, thank you. Our next speaker is Petra from EP Interactive and Massey University. Presentation titled Building a Global One Health Intelligence. So Petra, the floor is yours.
Okay, Ken, the unmute button. Classic. Yes. Okay, can you all hear me all right?
Yes, we can.
Awesome. Yeah, so thank you all for the opportunity to speak, and also to the group, you know, for organizing this event. It's kind of really cool that we all get to go together. So thank you very much. I'd like to talk to you today about some of the work I've been doing recently on Global One Health Intelligence with the quadripartite, and discuss a little bit or reflect a little bit also on other learnings from our work, you know, connecting science data and people through decision support tools and, you know, contributing to health intelligence. But before I start, I really want to thank all the amazing people we've been able to work with and that have kind of like inspired, you know, the work we're doing and where we're going. So it's really, I feel like I'm really standing on the shoulder of giants and been just really, really lucky and influenced by, you know, working with great people over the years. And I want to kind of just bring back a little bit one of my key philosophies of maybe why I got into this type of work is also, you know, because I'm a passionate epidemiologist and I was always really frustrated. I'm very practical. And I was always kind of really frustrated about like that, you know, tools didn't give us what we wanted, right? You know, they made you sometimes at best, you make you feel a little bit dumb, you know what I mean? And then that applies to computer-based tools or interfaces that we create as much as little machines that we try and get a subway ticket from, and so I have a great passion for stakeholder-centric approaches and designing things that make life better in day-to-day health intelligence. So I was very fortunate together with my partner Uli to work over the last 7 months in a project that was led by the quadripartite on enhancing One Health intelligence to strengthen global health security. So this is called the One Health intelligence scoping study. And again, I just really want to acknowledge, we're like a small wheel. It's a huge group of people brought together by different organizations. And and it was kind of like, it's really kind of like a teamwork that we were, glad to be involved in. And the little background of this project is that the G7 Garbis Bay Health Declaration requested quadripartite, which is the alliance of the Food and Agricultural Organization of the United Nations, the World Health Organization, the World Organization of Animal Health, and the United Nations Environmental Program to work together to connect the study to improve opportunities to improve and harmonize, their systems to strengthen global One Health intelligence. And as part of this work, there were a variety of activities, including various stakeholder engagements. We worked on a literature review, riskscaping to look how to capture One Health risks, did surveys and established a technical umbrella framework. And it was really about identifying also opportunities, elimination of current systems we use to collect, data and generate One Health intelligence, and how this could be improved and better shared to improve our understanding at the global level. And also to not only look inside, but also look how to strengthen collaboration with external partners. And so why One Health? You've seen this before, and this is actually where I know Barry from. We used to, One Health has been around for a long time. We used to work together on a One Health training, but it is a fact that, majority of emerging human pathogens have animal origins. So there's an increased understanding that there's a need to collaborate between animal, human, and environmental health to kind of address these health threats. And there's at the moment, as a consequence of COVID, really a huge energy in this space. A key example is the foundation of the WHO Pandemic Hub, that looks into epidemic intelligence and pandemic intelligence. And there's also the One Health expert panel of the quadripartite organizations, plus lots and lots of global initiatives. It's kind of like absolutely fascinating, how many people are working in this space and trying to help us evolve. So there's official definition as well about One Health, from the panel that takes together, the breadth of the topic. But I want to dive a little bit now into the intelligence space and, what we learned from it. And I think the first thing I kind of like asked when we started the project is really, what do we actually mean by intelligence? Because it is sometimes often still used, similar to surveillance. And but I do think that surveillance is really only one of the many activities that contribute to intelligence. So we've got various activities. So for example, here in a few examples that we found is, you have like outcomes from even expert networks, expert workshops, horizon scanning, early warning tools. There's a lot of stuff out there next to surveillance. And interestingly, and I think this is quite important when we think about technical framework, all these activities, while they provide intelligence, they're in very various stages or varying stages of digitalization. So a lot of this, not everything is computerized and gets put on a dashboard and in a database. A lot of it is really meeting people. So there's a lot of people-based processes that are great, but they're also maybe difficult to scale up, without, will require quite a bit of work. So it's really, and then in the division of the work we've been doing there, the zoom in was really about intelligence as a decision advantage and the value of intelligence to to help and fulfill functionalities that improve insight and therefore decision making. And I think one of the key challenges in the One Health space around it is really like what we call contextual or secondary data. So for example, the primary data sets like human and animal health cases or indicators, that's pretty straightforward and has been collected for a long time, but they try to now use indirect indicators of health, such as vaccination coverage or indicators used to assess disease emergence. So for example, in the One Health context, it would be measures of deforestation or livestock densities, or also measures of capability, capacity and vulnerability, which we've also seen in the previous talk, around social deprivation. It's really, really interesting, but also quite a technical challenge sometimes in how to include this into the analysis. But I do think that the vast of environmental data available, for example, also through the UN Environment Program of the World Conservation Monitoring Center, is quite huge and amazing, and probably also at this stage a little bit untapped into. In general, intelligence and, I could be defined as really like, and we've seen this is a variation on the theme of what we've seen before, that we're really looking at 3 different processes, like the data collection and management, then the assessment, early warning and rapid alert, how it's often referred to in this context, but, we also can call it analysis and, preparing those insights and then translating that into risk management and action, which is really the challenging that we are facing when we're looking and how to want to make this happen. And something I find really useful when looking at intelligent system is kind of borrowing a little bit from our thinking on surveillance evaluation, because when we evaluate surveillance, we often look at the surveillance system and look at a variety of contributing activities. So we can literally, when we, in this context, look at global One Health intelligence, we can actually look at lots and lots of individual activities, how they contribute, to the system level capability of individual organizations, and then how are these brought together at the next level towards the global system. So this is a little bit like, for example, a good example is that in animal health, we conduct like freedom from disease surveillance and this activity to be able to get it. So we've got a system that does that, corresponds to a couple of different distinct surveillance activities. So we actually got a variety of activities that underpin, high level intelligence system. And there's actually a publication, if someone's interested, that I've done in collaboration with the Ministry for Primary Industries a couple of years back, where we look at, surveillance evaluation and this hierarchy in the context of biosecurity. So one learning is also that when a key thing is, if you look at One Health intelligence from a data and application end, is that really the way forward is using a linked data model. And what we still traditionally find is a lot of siloed activities, but we have data production, we have a specific data user, and then the data gets archived and stored, and we have a really, really difficult reuse. And I think this is why looking at FAIR principle, especially at a global level, is really important, because if we store data with a schema, we move towards data harmonization, we can actually generate multiple data users, and they can be people, or as we've heard, also people and machines, or people or machines. And through embedding these findable, accessible, interoperable and reusable data principles, I think we can go a long way towards improving intelligence and improving the value we can generate from the data we have. And obviously there's many, many layers to this as well, which I'm not tapping into now, where we need to acknowledge data governance, privacy, access, and this is obviously very, very context specific. I think a really important learning is that dashboards aren't intelligent. We all love dashboards, and I personally really enjoy, that, everyone's getting into it and getting creative and is building dashboards. But I think the value of a dashboard really lies in the specificity of its functionality. And I think we've already seen some really, really great examples of that today. And I'm sure we'll see more of it as, different people from the network present their work. there's at any level, being it, what we've done with our clients or what's happening or the in the activities of WHO and other organizations on the global level, there is really a value of stakeholder-centric approaches and that multidisciplinary, which is really shining through, and huge opportunities because we get novel data, novel analytics, and we've seen this with genomic surveillance, big data, AI, and it's kind of like almost overwhelming. All the things are being done and very, very difficult to still see the forest for the tree. And I think linked to this here is, linked to like this specificity that we are throwing a very specific question to generate intelligence that supports a decision versus, just globally reporting on data. I think a very important discussion that is coming is the discussion of digital public good and open source tools. This also is a bit of an organization mandate, in the work we've done with the quadripartite. It's of course, their mandate to improve global health and support national capacity and capability. But I think in general, we're seeing those software as a service discussions and the opportunities for internal capability development. So we don't just develop intelligence tools that create silos, but tools that improve the status quo and where we're going. So it's really good to see there's this strong emergence of our Shiny in the context of health intelligence, so highly customizable code first dashboards. Highlighted just now, we also heard from Vaughn about GitHub and the R-based environment, how that's being used at their level. And my partner Uli is going to talk a little bit more about this and the opportunities we see in that, I think, next Friday. So I think this is kind of like, it's one of the many challenges, I think, of, intelligence to get that part right. I want to just highlight, just as I'm talking about it, so there is an example. The ECDC, for example, has done something really, really cool here. They have an epi-Twitter tool. I don't know if you've seen this, but it's a tool where we can monitor trends from tweets, by time to kind of, it's a threat detection tool. But the cool thing about it, they haven't just developed it, but they made it publicly available. So everyone can go, you can grab the code, and it even includes the dashboard, right? If you do this, so you get like the whole epi-Twitter tool, you download it, and off you go. And I think this is a really, really good example of, to improve intelligence, these capability sharing, that open source environment, how they can really, really empower global One Health, because we don't really have to, everyone doesn't have to develop the same thing in parallel. I think it's a learning from, the journey I've been through with the project. It's and kind of also stepping out of New Zealand into that global One Health intelligence space. It's been really a great opportunity for us to work also with the people, and always findings and recommendations will be available from August. So at the moment, we just have a small brochure that I've shared. And I think it's really interesting to acknowledge the unique perspective of the quadripartite in One Health intelligence and the data they historically collect and already have and are managing and reporting on. Also, they collect from different countries. So I think there is like really, really great opportunities. And then I think there are recurring themes, big and small, from the smaller projects we supported locally to, what's going on in the global level, and these really ambitious tools for pandemic intelligence and efforts like the Pandemic Hub or the business as usual operational intelligence that the quadripartite run. But a lot is like recurring themes are really multidisciplinarity, collaboration, people. And I think this huge phase of investment will, at all the different levels, will bring huge advances. And I think that the question really is at the moment is how can we amplify efforts rather than duplicate, because there's a lot of things going on at the same time. And personally, just as a note, as an epidemiologist, I appreciate really the energy and increased awareness and support for our work and, the field. I mean, it's also hard sometimes. I kind of found this image here, someone sent this to me, because when you start off as an epidemiologist, you kind of like to think in quiet about stuff, but it's kind of like really fast and lots going on and people want to know things. So yeah, it's been great fun, but and yeah, not too much hardship going to Rome. So I just got back on Sunday and my suitcase on Tuesday. Still a bit wild out there traveling, but yeah, FAO is based in Rome, so we had a team meeting, and that's of course always beautiful. So yeah, so lucky to have been there, and yeah, thank you for listening to my thoughts on the space. And you know, if you have any questions or like to connect, yeah, I'd love to hear more.
Thank you very much, Petra. Yeah, we'll open the floor to some questions. We've had one in the chat around where people can find the publications, and then someone's replied that it's most of them are all available online. Is that right?
Yeah, I'll put as soon as I'm kind of like out of my presentation, I'll put some links in the chat for you all if you want to read more. And as I said, the final report, you know, I can't preempt the findings because we're just writing them up, but as it is all public, isn't it? It will become available, but I'll direct you if you're keen to learn more, or email me.
Wonderful, yeah. Thank you. And I see Ron's got a question for you.
Thanks, Petra. Might not be directly at you, but around that concept of the Twitter tool, I forget what it was called.
Yeah.
I mean, we've got healthcare services have this concept of a patient-centric system.
Yeah.
Now, I kind of have the idea of a public-centric public health intelligence system and delivering information for public consumption. We've all seen how important the public narrative is around outbreaks and the like. I guess it's a question of, is that a capability that the sector or someone should be providing, or do we leave in presentation and the narrative to media?
Oh gosh, it's a deep question. I'm not quite sure. I think it's a really important question, isn't it? Because we've all seen this, isn't it? Especially now that it's very easy to create, you know, data visualization and insights, and you know how that links with good science and good science communication standards, and the risk of this being grossly misleading. So I do think it's important that people who understand, you know, the analytics and the complexity of it, you know, that we do make an effort to do that, do you know what I mean, to communicate our findings well, because if we don't do it, someone else will do it. And if we don't do it in an appealing, cool looking way, you know, people are kind of like, the attention span of people is very short these days. So I do think it's worth for us, like for many of the people we collaborate with, you know, it's also, you have the option of developing internal and external tool, you know, so you do the internal tools that do the trick. But I think the public now requests, you know what I mean, that you communicate well and share that in the right way. And including also the data, I mean, that's the other level of this, isn't it? With GitHub and stuff, you know, making data accessible, which is scary because, you know, then people can do stuff with it. So I think it's a big, you know, I don't have the answers, but yeah, it's a big Pandora box. And I think we really need to, yeah, if we don't do it, you know, it's people who have the training understanding, other people will. So I think it's important that we make our mark, yeah, and fight a good fight, yeah.
Thank you very much, Petra. It's a wonderful presentation. And it provides a nice segue into our next presentation by Ying Li from Health Quality and Safety Commission, with his presentation titled Turning Big Data into Knowledge for Healthcare Quality Improvement. So Ying, the floor is yours.
You're on mute.
Are you with us there, Ying?
Yep. Tēnā koutou katoa. Ko Ying Li toko inua. Good afternoon, everyone. My name is Ying Li. I work for Health Quality and Safety Commission as an analytics manager in the Health Intelligence team. The commission, also known as HQSC, we are working with clinicians, providers, and consumer and farmers to improve their health quality. Today, I would like to show you one of our routine report, which called Health System Quality Dashboard, and just to show you how to use it and how to generate the knowledge from it. So let's probably look at or watch a short video about this product and to see why we developed that and how this looked like.
We just don't seem to have any sound there. Was it meant to be sound?
Yeah, well, I need to have some sound, definitely, yeah.
Maybe you can narrate over it.
So how should I make the sounds working?
Is Patrick online? You got any advice there, Patrick?
It might be something she needs to enable on her end. I'll stand by.
Okay. Can you hear now?
No.
We can hear you, but not the video.
Okay. Okay.
Did you want to maybe move on, and we can always come back to the video once
Okay, yeah, sure. That's totally fine.
Sorry, team, a solution. Ying, if you stop sharing your screen, then restart the share. When you see the option that lets you pick which screen you're sharing, there should be a checkbox that says share audio or share sound as well.
Yeah, share sound. Okay. Right.
Who has the time to do that? Doctors?
Yeah, that's working.
Nurses? You? We didn't think so either. So we wondered, how can we make this easier? We looked all over the world and found that in Italy there was this brilliant artist, statistician, who realized that if you took an image of a target and drew a lot of lines onto it and made each line a scale of good to bad for a single measure, then you could show a lot of information in one place. And if you put similar measures next to each other, like different types of infection or what people thought about different aspects of their care, you could start to see patterns, making it easier to work out where you might need improvements. Brilliant? The Aussies thought so. They made a book using the same image, and we thought so too. But we had an idea. Why don't we make it interactive so you can dive into the data? So we had a think and talked to people who provide and use health services and created New Zealand's very own interactive healthcare dashboard, wrapping up 60 measures in one place. We brought some order by sectioning it into 6 domains of quality. For example, how safe is care? How did it feel to be cared for in our system? Did the right care get given? And so forth. So how does it work? You can click on each of the dots to see what's going well, or where some changes may need to be put in place. Warning: this is not a ranking system. Really? It really isn't. Why? Because you can't add up all the dots, divide by the number you first thought of, and come up with a score you can rank. Healthcare doesn't work like that, and neither does the dashboard. Healthcare is big and complex and messy. To understand what's really going on, you need to look at lots of different things, in different ways, from different points of view. So the dashboard is a way to start thinking about what questions need to be asked, and how we can answer them, so we, New Zealanders, get better and better care. As a quality improvement agency, we are continually looking to improve, and we'll add new measures to the dashboard over time. We would love to hear your comments, thoughts and impressions. In the meantime, we hope you enjoy exploring your healthcare system with a whole new spin on it.
Okay, so sorry for the technical issue. So this is the timeline of the health system quality dashboard. We first released it in the May 2018, and then we took the PDSA approach, which a lot of you have already know, Plan, Do, Study, Act, and we organized about more than 40 internal and external consultation during 2019 to 2020 to also workshop with people to get people's feedback. And also we co-designed the multi-health equity outcome report with Titumu Faklai. This is, they are the multi-strategic managers of DHBs. We add this report into the second iteration, which released in February 2021. And this dashboard now been updated quarterly, and we continue working on the PDSA cycle. So here is the second iteration of the dashboard. You will see the 8 tiles pretty much lay out the structure of the dashboard. The quality priorities, which highlights the priorities we identified from the dashboard at DHB level. And then we have the multi-health equity report, which I just mentioned. And then the dashboard follows the Institute of Medicine's 6 domain of healthcare quality, timely access, safety, effectiveness, patient-centered, efficiency, and the equity. Because equity embedded into each of the domains, so it's not the tile will separate page for each of the domain. So let's look at the multi-health equity report. This is on top of this title, and in the bottom you can see some navigation button to help you to go to the previous or next page. Here is the filter section. So once you set up the filter, the whole page will reflect to the filter you set up. And this is the pattern. We show the pattern as a data board. Then we divided the data board into slides to represent things. Like, for example, the overall health data and the sickness and the hospitalization and so on. And then we put the indicator which related to each other to close to each other as a monger. And so if you see a pattern show on the data board, which is meaningful because they are the indicator is related. So at the moment, we set up the filter as multi compared with non-multi, non-Pacific at DHB level. But the DHB we actually select is a national. So we see all the monger actually located outside the green ring here. The green ring means the equity, which means multi have a similar outcome and experience with non-multi. Everything outside the green ring means the multi experience worse outcome. And inside the green ring means multi experience the better outcome. So in this current data board, we can come to a conclusion that at national level, those indicators we selected indicate multi have worse outcome at national level. If we want to look at particular indicator which need to hover over on the monger, then we will see this is that indicator, which is immunization rate for 2 years old. If we click the data link, will link us to the MOH website of the immunization. And once we click the monger, we will change the right-hand side of the page. The title is this indicator, and the arrow means the higher the better. And then we have the measure and impact section, give us the currently for multi is 72% and for non-multi is 92%. The impact of that is if we apply the non-multi rate to multi population, we should see 155 multi children be immunized in that quarter, but actually we see 122, which means 33 multi children, fewer multi children being immunized in that quarter. If people want to look at change over time, they can go to this chart. The black line is the non-Māori rate, and the green one is Māori rate. We see before the COVID pandemic, Q4 2019, Māori is 93%, which pretty much reached the highest of Māori rate, and then it took a downward trend up to Q1 2022 is 72%, but non-Māori pretty much remain above 90% rate. So we see the enlarge of the equity gap, which is quite clear shown by this line chart. And at the bottom of the variation is to look at the difference across all DHBs. So the selected DHB is highlighted, and the bar actually ordered in from the low to high as a Māori rate. And the lower end is about 50 to 60% of this rate, and the higher end is above 90%. For this select DHB actually is in the middle. So because that, we highlight this immunization rate as the quality priorities for that DHB. So you can see this from this page, from the quality priorities page. Other domain of this healthcare quality, for example, effectiveness and safety and other domain, all structured in the same similar way. We have filter data boards to show pattern and the measures for the current result and the change to help you look at over time and the variation across DHBs. So if people want to look at the equity of that particular effectiveness domain, they just need to click the domain equity button. Then they will see this chart or this page. So on this page, what I want to highlight is the impact table that lists all the indicators we selected for the effectiveness and calculate the p-value to show whether this difference is statistically significant. And for the impact, for example, the hospitalization for the acute condition, which is acute hospital bed days, we see if we compare Māori with non-Māori of the selected B, we will see 1,100 more hospital bed days for Māori in that 12-month period compared with non-Māori. So this is quite significant difference. And this is the equity link on the effectiveness. If people want to compare two DHBs, they can use the DHB comparison page. So you can see this is you can choose one DHB and choose another DHB and choose all the indicators you want to look at. For the two data board, they will see the pattern for the indicators you selected. So that is the DHB comparison page. For the future work, I think we will continue doing the PDSA cycles, and this health system quality dashboard actually fit into the quality alert, which is a new product released quarterly as well. And we're going to also make the connection with the new health system to present the new health system to assist the local and national improvement. So in summary, the health system quality dashboard, which is an interactive tool, and it is available on the Commission's web page. You can access to it. You can download it as a dashboard or as a PDF report. So here is the link of the dashboard. At the end, thank you for everyone. Thank you for your time. And if you have any questions, happy to answer. Thank you.
Thank you very much, Ying. Yeah, open the floor to questions.
Yep.
We had some comments in the the chat around such a cool tool, which it is. Looks very good. No, there's no questions. Any comments? Yes. Okay, well,
I'll put the link into the chat. Yep.
Yeah, that'd be great. Thank you very much if you could do that.
Cool.
Peter, you've got your hand up.
Thank you very much for that presentation, Ying. I noticed that you had the Māori group, and as the comparator group, you had non-Māori, non-Pacific.
Yeah.
How long have you been using non-Māori, non-Pacific as a comparator, and do you know why you use that group?
So this is to identify for the purpose of this page is to identify the equity gaps between Māori and other ethnicity. And because some of the data is for the Pacific also have some feature, so we want to eliminate the feature from the other side of the comparison, which means we compare Māori with the other ethnicity, but non-Pacific and non-Māori. Just try to identify the equity gap. So that is why we choose non-Māori, non-Pacific. And the other question is how long? So normally once we present this indicator, we try to start the indicator from the data what available to us. So as this dashboard is started from 2018, available to public, and the data, some of the indicator back to 2005 or 2006. So it's depend on the availability of the data, but we try to, in the Māori health equity page, we try to identify the equity gap.
Thank you for that. What I was kind of like getting at was that earlier, when I first started doing statistics, we always used Māori and non-Māori, and just recently in the last 4 or 5 years or so, it's changed to the non-Māori, non-Pacific group as a comparator. That was the only comment I was making. Thank you.
Thank you. Thank you.
Thanks, Peter. Thanks, Ying. I see no other questions. Karen's got one here. Good to compare with non-Māori, non-Pacific. Gives a much truer picture. Yep, thanks for that feedback there, Karen. If there's no further questions, then I would just like to summarize the day by saying that it's been an extremely insightful day. We've had some wonderful speakers, starting off with Mr. Verrall and the DG, of course, and then heaps of examples of public health in action, good examples of how the data is used practically, which is pretty much why we're all here at the end of the day, isn't it? So I'm not too sure if you want to add to anything, Barry, before we finish up with the closing karakia.
Yeah, I'd just like to thank everybody that's participated. The numbers are still well up, a bit like a polling on election night to be keeping the numbers up. I think the wide range of presentations is part of what PHONZ is about, to show people, showcase their own work. What has come out, I think, is that there's a hell of a lot of great work going on that hasn't actually been shared. It's been kept in, as we've said before, in the rooms and the offices, wherever they are. And I think this is something we want to encourage people to get out. So thank you to all the presenters. Once again, I'd like to thank the guys on the people, not just the guys, everyone on the steering group for their assistance and support, and probably our backroom Patrick, who has been not only timekeeper, but actually facilitated much of it. And so well done, Patrick, on behalf of everyone. But thank you, and we look forward to continuing the discussions next next Friday and the Friday after. So yeah, thanks, Tim.
Me karakia tātou, whaia, na uratanga o te manatū hau ora, ko te manikitanga, ko te kaitikatanga, ko te whakapono, ko te kaukiri ngā tahi, kia pā autu, te tau ka pai tata, kia pai tai whiti, kia pai ora, kia turu, kia whakamua, kia tina, humie, huie, tai kie. Ka pai, thank you very much, everybody. I look forward to seeing you all next Friday.